Good morning, everyone. I am very pleased to welcome you to the second day of the conference about real-world evidence. Thank you for having followed the presentation yesterday that were mainly focused on the pharmacovigilance, the signals raised, and with the example of the COVID, the big data generated during the COVID-19 pandemic. We talked yesterday about the organization, the infrastructure for the networks, about databases. And today, for the second day of the conference, we propose you to slide a little bit from the post-authorization to the pre-authorization and the use and construction of real-world evidence in connection with clinical trials. For this session, I am very pleased to present you Antoine Pariente, who will moderate this session this morning. Antoine Pariente is a professor of pharmacology and pharmacoepidemiology at Bordeaux University, director of Public Health Department. He is coordinating Drug Safer Center as a partner of EpiPhar. He is head of the research unit head of the Bordeaux Population Health Research Center. He would be helped by Isabelle Puff for the chatting. I advise you to raise your question during the presentation of the speakers, allowing us to take all the questions for taking it during the question and answer session. Please, Antoine, I give you the floor.
Thank you very much for your very kind introduction. It's a privilege to be here today, and I want to thank the ANSM for the organization of this conference in the context of the French presidency of the European Commission Council. It's really an honor to be here, and I want to say good morning to all of you, or maybe to a late morning, depending on when you are or where you are in Europe. The session today, as told by Vincent, will focus on going beyond pharmacoepidemiology and pharmacovigilance. So it's going to be more digital, it's going to be more connected, and it's going to be probably more what our present look like and the future will look like. And we will have 1 hour and a half to discuss all of this. A first presentation will be made by Professor Franz Schäfer. After that, we will have a small talk for 10 minutes with questions. So thank you for preparing them. And then we will have 2 other presentations by Roman Consari and Joanna Seppänen. I hope I give a right presentation of her name that will end the session by 10:30. So first, I would like to welcome Professor Franz Schäfer. Professor Schäfer, are you connected? And can you hear me? Well, maybe not completely now, but it's not, and maybe yes, because you can see the slides, and it's not really a problem because I have the huge task to present Professor Schäfer, and to be honest, the complete presentation of Professor Schäfer will take the 20 minutes he has to make his talk. So I will do quick and try to respect the main aspect of his professional career, which is quite extensive. Professor Schäfer is a professor of pediatrics and nephrology at Würzburg University Medical School. Oh no, he received his MD at Würzburg University Medical School and is acting now at the Heidelberg University Hospital. So his main interests are on kidney disease and rare kidney diseases. He coordinated numerous and very numerous research and international trials and collaborations on the investigation on kidney diseases, with aspects running from GWAS analysis to, at least from what I read, the mathematical modeling of the moves on the nephron progenitor cells, so quite a holistic view of the kidney diseases and rare kidney diseases in the children. Professor Schaeffer, if you're ready, floor is yours. At the moment, we cannot hear you. Maybe your mic is mute, or it's here that there needs to be some fixing. I will tell you when we hear you. Can you speak again? It's quite low. I think I can hear, but very tiny. I'm speaking in front of me, making like if I can control something, but is there a sound coming from Professor Schaeffer? Well, the good thing is that we have seen your slides, so this part works, and we can see you very well. This part works also, and you do great.
I can hear you.
And now we can hear you too.
Very good, very good.
So,
all right. I cannot see my slides now, but maybe.
And your slide now is projected. You cannot see them from your price? No. Okay.
No.
So maybe, and I think this is the second slide that we can see now. It's on the ERN-wide patient registries.
Okay. So. So I will.
And now maybe you can see both of them.
I can see it. Yes. Okay. Very good.
Okay. Great.
All right.
So is it your first slide, or do you want us to go back?
Well, it's the second slide, but it's fine.
Okay. Fine. So. Floor is yours.
So thank you very much for the kind introduction. I'm very grateful for this opportunity to present our work on the ERN registries. So as you know, the European reference networks, there are 24 of them, have been installed by the European Commission to improve care and also research for patients with rare diseases. I am coordinating one of these 24 ERNs, which is the kidney ERN ERCnet, and we were among the first five ERNs that were funded by the European Commission to construct ERN-wide patient registries. So there are 30 million patients with rare diseases in Europe, and about 2 million are probably treated in the European Reference Network centers. We have about 1,600 centers now in Europe that belong to these 24 networks. And having this huge amount of patients is a unique opportunity to collect demographic information, natural history information and outcomes data, and also some information on the efficacy and safety of disease management. So the EU started in 2018 to ask 5 of the ERNs to develop ERN-wide registries. And the next slide, please. And 1 year later, can I have the next slide? Yes. The other 19 ERNs also received grants through the health program of the DG Santé to develop their own registries. So now there will be 24 ERN-wide registries. And since 2019, also the European Joint Program on Rare Diseases has been implemented to support research for rare diseases. And we have another project since last year, which is called ERICA, the ERN Research Coordination and Support Action. And these two projects provide infrastructural support for the harmonized development of these ERN registries. And we really aim to make these fair. So the data should be findable, accessible, interoperable, and reusable. And that is what I would like to talk to you about today. Next one. So when we started the the ERN registries, we basically had two choices to proceed to collect information from these 1,600 units altogether. And one approach is the classical centralized data collection. Maybe you can click on the slide to advance. Yeah, which means that the data is collected from the sites and stored in a central server or a cloud solution. This has the advantage that you have very efficient data processing, and you can analyze the data collected very flexibly. Of course, there are the GDPR requirements to obey, and also the collection of the data is rather burdensome. But automated data capture from the hospital's electronic health records is currently basically not possible yet, because the systems are not as advanced, and the data are collected in the hospitals partially in an unstructured format. And so we have also fragmentation of individual IT systems in the hospitals. So that seemed to be a very cumbersome approach. And can you click again? So we decided for some of these registries, including ours, to go for manual data capture at the sites. Next one. The alternative is the federated data collection, which has advantages in with regards to data privacy insurance, but it's even more cumbersome to program the data extraction or the data, make the data available at the hospital site level. And you can do that usually only for a very limited set of data. And if you have unstructured data, federated data collection is, of course, not a solution. So about 2/3 of our registries are going for a centralized approach, and 1/3 are going for a federated data collection approach. Next one. And the next, please. So what data are we collecting? Well, of course, the different thematic ERNs are collecting different kind of data, but we all agreed to collect a minimum set of data in the same standardized way, and that is what we call the common data elements for rare diseases. It's a set of 16 items, including the age at onset, diagnosis, the diagnosis itself, genetic data, and whether a diagnosis or not has been achieved, and also whether the patient is dead or alive or dead at the current time. So this is the minimum data set that we are collecting from all the patients. Next one. So in the kidney disease registry, which is maybe one of the most advanced of the 24, we decided to have a very slim centralized data collection and add to that additional data items that are of interest. Can I go to the next one? Yes. So there is a core data set which contains of basic data elements, which are basically the common data elements, plus longitudinal data collection. The data is collected once a year on the treatment modalities, the kidney function, and so on. And then there are also more comprehensive data, which are collected in a disease-specific way. So for certain diseases or disease groups, we are collecting more extensive information. Next. And the registry started actually very successfully. So within the first 3 years, we have been able to enroll more than 1,000 patients with all kinds of rare kidney diseases. Next. And we have a lot of active sites, about 70 sites now are currently active, pediatric and adult nephrology units all around Europe. We are now active in more than 20 countries with this registry. Next. And on top of the core registry, we also added to this registry in a kind of modular fashion disease-specific, what we call sub-registries. You can see here the individual diseases where we are interested in collecting more information in a very disease-specific manner. And we are adding more of these sub-registries to the core registry. And we are starting to collaborate with the medical societies, the pediatric and adult nephrology societies, with patient foundations, and also we are intending to work with industry in the future to add specific data collections on individual diseases of interest. Next. Another feature of this registry is that we can obtain information on key performance and outcome indicators that we are collecting from the individual patients, and we can provide performance statistics to the sites, to the participating specialist centers, to show them how well they are performing, how well their patients are treated in relation to the overall registry community. So we allow automated benchmarking by participation in this registry. This is a unique feature of this particular registry, but it's also being looked at by other registries, that this feature should be added to provide added value from participation in this registry. Next. So to harmonize and streamline the progress of the registries, which all share common problems and tasks, ERICA and EJPRD have installed working groups for data collection, integration, sharing, verification, and ethics and legal aspects. And in these working groups, we have, in the last 2 years or so, we have done a lot of work, and maybe you can advance the slide. So we have agreed on the joint use of common data sets and interoperability standards. Next. And we have produced documents. So we have developed a generic informed consent form for the patients, which is GDPR compliant. It's available in all European language, thanks to a grant from EJPRD, and pediatric versions are also underway. Next one. We have also developed standardized templates for collaboration documents like data transfer, data processing agreements. And finally, next, we also have worked out the principles of a common data access policy for the ERN registries. All of these are proposals that can be adapted according to the individual registries' needs. So we have this data access policy document. And next. And because this is something that we have been thinking a lot about in the last couple of months, the aspects of data sharing once they are collected in the ERN registries. So we have to be aware that there are different types of contents that could be shared, not only the common data elements, but also disease-specific data items of phenotype, intervention, and outcome data. Next. We also have to define in how much detail we would like to share data or make data discoverable. Should we only allow counts to be found, patient counts with a certain feature? Should we share aggregated data, anonymized patient-level data, or pseudonymized patient-level data? Next. When should these data available? And next, and to whom? There are a number of stakeholders, researchers from inside and outside the networks, national regulatory and authorities, administrative authorities, patient organizations, and also commercial stakeholders. All these options are discussed in the data access policy that we are developing. Next. So regarding collaboration with industry, making use of the data collected for clinical trials, we have initial experience in our ERN registry, where we broker sponsor contacts to sites who have patients with certain rare diseases to industry that would be eligible for clinical trials. So we know where the patients are, and we can get the companies in touch with potential investigators. That's a low-hanging fruit that works very well. In other registries that I have been involved in, like the International Pediatric Dialysis Network, we are also collaborating with industry by providing aggregated patient data that can be of patients who receive drugs that can be used as supportive evidence as part of a pediatric investigation plan. And in another study, the 4C study that we have run, we are using fully anonymized patient-level registry data to create an external control arm for a clinical trial of an anemia drug. So these are examples how such data in principle can be used, provided that all legal and ethical and data protection requirements are met. And all these applications are potentially possible also with the ERN registries. Next. Next slide, please. Oh, no. Hello? Hello? Hello?
Did you lose the connection, Professor Schäfer? Because we can still see you and see your slides.
Okay.
It's on the one on the verification and the knowledge. You cannot see it.
No, I can only see the last slide with the data sharing with industry.
Maybe we can just go backward from a slide and then go forward just a little.
Well,
it seems to be
but you can hear me?
Yeah, sure, we can hear you, and it's on the slide at the moment with the green upper part on the resources, and then the lower part on the verification of the knowledge.
All right, so I cannot see the slide anymore, but never mind. I have
very sorry for that.
Presentation open locally here, so I can also continue speaking while you show my slides. So in the European Joint Programme for Rare Diseases, we have developed what we call a kind of ecosystem for rare disease data. It's called the Virtual Platform. And in this virtual platform, we allow interested researchers or anybody interested in research data on rare diseases to find such information. And maybe you can look for, you can go to the next slide. You can see the slide with the blue bars.
Yeah, exactly, with the kind of browser.
Okay.
Yeah.
So in this system, you basically can search for a disease of your interest. So here I added ADPKD, which is one of the kidney diseases, and then the system searches simultaneously in various resources for information on this particular disease. And it searches knowledge databases like the Orphanet, databases of cell cultures, animal models, disease pathways, and also the BBMRI-ERIC, the biobanking infrastructure. And we are also adding the ERN registries to that system. So you can see quite a few hits were found here. And if you go to the next slide, I must advance my slide here as well.
We have
yeah, you can see that, you know, the system found that there are 1,116 patients with this particular disease in our kidney registry. If there was a disease that is represented in more than one ERN registries in the future, we could see all registries that contain patients of that kind. And also, you can see that in the BBMRI-ERIC, there are 13 biobanks where samples of patients with this particular disease are contained. So this system, which is now in a prototype version, will soon be finalized and implemented, and we hope to make a contribution for rare disease research by this tool. Of course, we will have to clarify all the authentication and authorization issues, who can see what, who can search for what, but this is something that needs just to be defined. Next. The next slide is this one, yes. Yeah, and then you can also filter for instance, for age ranges, for sex, for the country of residence, and so on. So if you have the permission to use these items, to search by these items, then you can also make refined researches according to your interest. So this is something that has been a lot of work to establish, but now it's almost ready to be launched. And the EJPRD, of course, is a limited program, and it has a lifetime. It will end in 2024. And what happens then? Well, we will have the Rare Disease Partnership, but also we will have, and please go to the next slide, which is the last slide. We will also have the European Health Data Space available, very likely. And the ERN registries will become part of this European Health Data Space. How we can use or how we can be integrated in this system is something that is currently being worked out and considered and negotiated. But this will be the future, that we will have these data available in some way for discovery through the European Health Data Space. And I think that is all I wanted to share with you. Thank you.
Thank you very much, Professor Schäfer, for your presentation, which was very interesting, very clear. I have one first question coming that concerns the data sharing of what can be included as incredible information in the registry that you presented. And the question is for the sharing of the data, does the ERN use the OMOP common data model?
Mm-hmm. Yeah, indeed, we are working towards the OMOP. So our ERCREG registry and another one will be the first two registries that will be mapped to OMOP. We have grants from the EDEN collaboration with industry and IMI. So we are in the process of mapping the data items to the OMOP standard.
Yeah, so this is a complete answer to the question that was raised within the audience. I had several questions myself in the view of the incredible work, I think, that was done to constitute these registries. I think the scale is amazing, both in terms of number of structures that were combined and in terms of patients included today. And in your presentation, you make it look like it quite always existed, or it was simple to do so. What I cannot believe, can you just maybe tell us in a few words what were for you the major challenges that you faced, or the major barriers?
Yeah, it was not as easy as I made it look like. Yep. You're right. You know, the major challenges really are maybe not the technical ones. Technically, to construct a database, you know, and have it filled by users is not so difficult. But the major challenges are, number one, the ethics approvals. Despite the existence of GDPR, we still have the autonomy of the local ethics boards in many countries. And, you know, in our registry, we started with 35 centers. We had feedback from 35 ethics boards, which all were a little bit different. And we had to comply with all of them. And that was extremely laborious. So this kind of bureaucratic effort is probably the greatest stumbling block currently for the other registries as well. And the other thing is, of course, to feed the registries. Well, if you have a federated system, it's not so difficult. But if you have a centralized system, you have to have people on the ground in the units that feed the registry, that collect the data. This has worked surprisingly well by a lot of, let's say, enthusiasm by the members of our ERN, and also by some financial framework. We were able to support in the larger centers from the central budget people who do the data capture. So some level of support is required for that. And now with the new grants that are coming for the ERNs, we will also receive more support through DG Santé for that purpose. Yeah, these are actually the two bottlenecks: ethics and data capture.
Thank you very much. And probably, but this is a thought from my part, I think that this was maybe eased by the fact that it involved people that were used to contribute to clinical trials that can face the same difficulties in both aspects. And being on the observational side, I think we would have been very much less efficient than you were. So thanks a lot. The other question was relating to the quite huge number of patients that you have enrolled for rare diseases. It's quite of paradoxical, and you mentioned that some sub-registries were going to be constituted. What is the size that can be envisioned for those rare diseases? You mentioned Alport diseases, for instance, or I think Goodpasture. I'm not sure what number can be reached.
Yeah, well, you know, if you have like 15,000 patients almost in a registry covering all rares, of course, it breaks down into almost 300 different diseases. But you do have sizable cohorts, or we have sizable cohorts for the major diseases like Alport. We probably have 600 or 800 of them in the registry now. So all major diseases are now represented quite well. ADPKD is the most common one. We have maybe almost 2,000 patients with among the 15,000 with ADPKD. So yeah, we are coming up now to really strong numbers, and even the rare and ultra rare diseases are now starting to be represented. So we are now starting to find also those diseases where there are only very limited numbers. But you have to reach a critical mass before you can really, you know, exploit the potential. And by and large, now our active centers are following approximately 50% of the overall cohorts that they have set to be following when they applied to become an ERN center. So we know that we still, you know, have a potential of about 50% from the founding members, and then with the recent expansion of the ERNs, we have just doubled in size. So, and those centers have not yet started to contribute their patients. So eventually we will have a potential of at least 30,000, 40,000 patients with rare kidney diseases in this particular registry. If you multiply these numbers by 24, then you see, you know, we will at some stage, I'm sure we will have about 500,000 patients with rare diseases in the 24 ERN registries. That's the aim.
Well, that's a great aim. And my last question, you answered it in your last slide, was your sustainability of that amazing system and its integration potentially, or its positioning within the Darwin EU initiative and the European Health Data Space, but you already answered to that. Thanks a lot, Professor Scheffer. I think this is the end of this first part of the session today. It was really great having this presentation and seeing what will be done in the future regarding rare diseases, with the example of kidney diseases that you present in pediatrics, and there will be a lot of questions that can also liaise to that with the next presenters. And I'm very happy to first meet second present here, Professor Romain Consary, who is the medical director of the Health Data Hub in France. Professor Consary is a surgeon, from what I know, and is quite had made a name by using 3D printing for otorhinolaryngology surgery and stomatology surgery, but not only. And amongst the many interesting work he contributed to, I could see also a publication on the injuries of head and neck related to scooter use in Paris, and that was quite interesting also. Great number of interest, including, of course, the Health Data Hub is going to talk about right now. Dr. Consary.
Thank you a lot for the invitation. So I'm going to present you briefly what the Health Data Hub is in 7 different aspects. It's a new component of the French health system. It was created in 2019, and we are already quite a busy administration, and we have lots of projects going on. So I'm going to try to sum up our activities, our goals, and why we exist in the 7 main topics. So maybe we could start the presentation. Next slide, please. Yeah, so the Health Data Hub was created to address a very common concern. That's obviously it's a national concern in France, but it's the same in all the European countries and also at the global European level. Next slide. So this concern relies on the fact that we have lots of data available in registries, in hospitals, in various kind of private companies, in cohorts. The medical data is really spread. And obviously, using data brings lots of benefits to patients. We can address scientific questions. We can use data to improve the management of patients. And we can also use it for global epidemiological questions. And this has been particularly acute during the COVID-19 crisis, where everyone in the global population realized the importance, the social and political importance of even the most simple and basic epidemiological research. So data exists. Data is very useful for many reasons, but next slide. Data is also a bit difficult to use now for many reasons. We could spend hours on this slide. There are lots of limitations to the current use of data. One of them is was mentioned in the previous slide, is that it's really spread between different sources, but other limitations also exist. For instance, philosophical limitations related to data sharing, lots of issues related to the funding of the data sources. The lack of valorization of people who work on data. For instance, when you're a doctor and you build a database in France, there is no proper valorization of your work, either financially or academically. So there are lots of limitations for the use of this really precious source of potential improvement for patients. Next slide. So the Health Data Hub was created in 2019 it was a decision of the president. After a global study on the use of AI in society led by Cédric Villani. And this Health Data Hub was created in order to federate the world of data in France and to create a platform that would be accessible to all the people involved in healthcare, to be the unique platform to access data. Obviously, the Health Data Hub doesn't have the aim to group all the data of the country. That would be technically impossible and not a good strategic choice, but still we want to be the main gateway to access data and an easy, unified and transparent way and secure way to access and use this data. So that was the very global statement of our mission. And now we're going to see more in details how we built this mission step by step. Next slide. So the Health Data Hub is an institution. So in France, we like administration. So it's a large institution that's correlated with lots of other national and private institutions. So we interact with lots of other components of the world of healthcare in France, notably the CNAM, la Caisse Nationale d'Assurance Maladie. For instance, you will see how important is this collaboration in the future. Obviously, the Minister of Health, healthcare professionals, hospitals, cancer centers, industry, startups. So there is a whole network of actors with which we interact and which are part of the General Assembly of the Health Data Hub. Next slide, please. And all this is to facilitate the access to data for all health professionals. So there is this unique gateway. You will see in the next slides what we call the collection of databases, which is one of the parts of the Health Data Hub. And based on this gateway and this collection of databases, we have developed a series of state-of-the-art tools to use this data. And we are also building a network of people that we bring together to work on this data. And our aim is to federate the ecosystem of people working around health data in the country. In order to access data in the Health Data Hub, there is a gateway that we have developed, and it's despite the fact that it's highly facilitated, it's still highly secure and well monitored. So there are mainly two steps to access the data within the Health Data Hub. The first step is going through the CESRES, which is a committee that judges the fact that the projects have a proper public interest, because we only focus on projects that will improve the care of patients and have a real public interest. So the CESRES is an independent committee that states the value of the project. And then the CNIL, which is a very important institution in France that controls the security of the use of data, which also states if the project is in accordance with all the security requirements in order that the data of the patients will be used according to all the security rules. And after passing those two gateways, the health professional can access to this precious data and work on it. Next slide. So in really briefly, we have lots of different projects that have been submitted to CESRES, lots of different projects that have been submitted to CNIL as well, from a really great variety of actors. So healthcare professional, industry, hospitals, scientific associations. And what we aim to create is the simplest way for healthcare professionals to access this data and cross those steps with them and help them to have the easiest path to reach this data and work on it. And it's based also on another fact that in France, currently reaching the data is a very long and complicated process. So our work is also to facilitate this process and make it faster. Next slide, please. So this was the first point, like the general statement about the Health Data Hub. One of the specificities of the Health Data Hub, which is related to the fact that it's a French database, is the fact that we rely on what we call the SNDS. The SNDS is a French specificity. Next slide, please. And the SNDS is a national database that comes from the fact that we have a national social security system in France. It's a very rich database, which is composed of three sub-databases. The SNIRAM, which contains all the medical acts that are reimbursed by Social Security, the PMSI, which includes all the codes of what is performed in hospitals, and the CEPIDC, which records all the medical causes of casualties. So all those three databases taken together constitute an extremely rich source of medical data, but they have been designed for medico-economical purposes. So and first, they have been designed for medical economical purposes, and then second, to access this data set is quite complicated, it's long, and it's also really reserved to people who are already very familiar with data, the world of data and data analysis. A random consultant in surgery or in a medical specialty in a hospital who has a great personal project will have a really hard time accessing this data with the current system today. So first, this data is not designed properly for medical or scientific research, and then it's hard to access. This is the next slide, please. But the SNDS is still a source of very interesting projects. So it can answer lots of questions. For instance, if you have, we'll take an example, if you have a database of patients with heart disease, and you want to see what was their use of medication during their whole life before their admission to the hospital where you're studying this data, you can combine the data from this hospital with the data from SNDS, and then you'll get all the medical history of the patients and put them back into their global clinical context. So it's a very, very rich source of medical information and very, very rich source of potential progress in the understanding of disease and care of patients, but still it's not that easy to use for now. The access is complicated, and combining SNDS data with hospital data is still tricky. So this is what the Health Data Hub aims to facilitate. Next slide, please. And so as a manager of the SNDS, the Health Data Hub will try to operate a transition between the fact that this data was available through different platforms, but most of them were really reserved to people who had lots of familiarity with the world of data. And it was also taking lots of time, and there were no really dedicated tools to work on this data. And the last point was that it was quite complicated to combine this data, which was medico-economic, with hospital data, with the diagnosis and with other medical details. So what we want to operate is this transition, and as you see on this slide on the right, we want to create tools, facilitate access, and facilitate linking with other sources of medical data in order to exploit all the potentialities of this SNDS, which is really unique and could bring lots of progress in the management of patients. Next slide, please. So the third point I wanted to address is the fact that the Health Data Hub also relies on a catalog. I mentioned this earlier in the slides. The catalog is an internal list of data within the Health Data Hub. Next slide, please. And this catalog is very diverse, and every year we increase the list of data within this catalog, and it's a list that's validated by independent structures from the Health Data Hub. So we propose a list of elements to include in the catalog, and it's validated, and it goes through lots of checks of security and ethics and everything. And when we have this list of this yearly list of data, it goes into the catalog of the Health Data Hub. And what's the point of having this internal catalog is that, first of all the data has been selected for being particularly relevant scientifically, and it's also selected for the fact that it can be used to answer many different scientific questions in the future and used by many different healthcare professionals. And also we facilitate the linking of this data with the SNDS. Once it's in the Health Data Hub, it's easier to link those databases with each other, but also to link them with the SNDS. So we believe that by increasing this internal catalog, we will little by little create a local ecosystem of very precious data on which many different projects will be able to work. So this is an example of the really small list of the data that are or will be included within the catalog. Next slide, please. So what we aim to do is to enrich this catalog little by little by building partnership with hospitals. Of course, hospitals are a great source of data for the catalog. We built also a partnership with, for instance, cancer centers, and cancer centers already have their own system of federating data, which is called UniCancer, and we work with them through the UniBase project to coordinate and include some of the data of the cancer centers within the catalog of the Health Data Hub. And we also work, for instance, in 2022, we'll focus on outpatient care data also to include new types of data within the catalog. Next slide, please. So the fourth point I would like to underline is that the Health Data Hub offers not only data, but also an environment, technological environment to work on this data. People who want to work on the data need to know what data is available. So we are working hard to build a metadata catalog. So project leader will be able to identify what is available within the Health Data Hub. And on a larger scale, we would also like to extend this on a national level and go beyond what is within the Health Data Hub and offer a service where people will be able to locate where and what is available in France in the world of medical data in order to direct their studies and build their network of collaborators. Next slide, please. And once the data is selected and prepared, we offer high security tools and functional tools to work on the data on the platform of the Health Data Hub. So there are two possibilities. People can work on data from the catalog, which is already on the Health Data Hub, but we can also shelter studies that will never go into our catalog, but people will be able to work on our high technology and high security platform on their data, and once the study is over, then leave the platform of the Health Data Hub. So they can also work on our platform, for instance, to facilitate the linking with the SNDS. So it's also a technological platform that's offered to a large array of studies on data, independently of what's available on our platform. Next slide, please. And this technological offer is enriched day by day. We have a scientific and we have lots of scientific groups working within the Health Data Hub in order to develop new tools. For instance, to explore the SNDS, which is a database which is quite hard to use when you don't have the right tools, to improve the metadata, and also every time we have a new projects coming in, we offer the possibility to develop a custom-made tools to answer the specific questions of our partners. Next slide, please. And also we obviously, if we want to work on data, one of the main questions is optimize the access and the use of this data, and also have a long-term view on how this data can be shared. So for instance, we work hard now on the homopization of data. So there is a team in the Health Data Hub working on transforming various standards into the OMOP standards in order to anticipate at the national level the sharing of medical data within different centers. The fifth point I would like to underline is the fact that we have projects now on the Health Data Hub, real projects going on that could really be examples of how this structure could change the world of data in the country. I'll give you one example. So those different projects, it comes back to what I told you earlier. Data comes from different sources. And they use our platform to put this data from different sources together and to create a scientific value from grouping this data within our platform using our computation facilities and the tools that we can develop with them. Next slide, please. There are lots of projects going on within the Health Data Hub now, with data coming from different sources. Of course, we had lots of COVID projects, obviously, but there are also projects coming from various call for partnerships, and projects directly proposed directly selected by the Health Data Hub because they had a specifically strong scientific value. Next slide is an example of one of those projects. It's the Hydro project. The Hydro project uses data from pacemakers, and we combine data from the pacemakers. We bring them within the Health Data Hub. We link this data with data from the SNDS, and using this combination of sources, we can screen for predictive factors of various types of rhythmic disorders for those patients with pacemakers, and try to find early signs that would predict some serious rhythm disorders, and try to improve the care of these patients by focusing on the prediction of those rhythm disorders. Next slide, please. And obviously, in 2022, we would like to focus on real-world evidence and try to build partnership, notably with the Autorité de Santé, Haute Autorité de Santé, HAS, to include this type of data, which is a real major technical challenge within the Health Data Hub. The sixth point I would like to emphasize is that the Health Data Hub is also federating the ecosystem of data in France. Next slide. there are lots of events on which we take part and that contribute to familiarize health professionals with the questions of data. For instance, the BOAS project was a call for projects to build innovating algorithms to explore the SNDS. So we are now working on the winning projects, and they're going to be supported in eight projects won this call, and they're going to be supported through the year to build new algorithms with innovating techniques like AI techniques, for instance, to explore the SNDS. Next slide. But the BOAS project is not the only one. There are many events in which we take part at the French level, at the European level, but also at the international level, and which are intended to build an ecosystem of people working on health data. For instance, there is a series of data challenges that are going to be launched in 2022 with various French scientific societies that are intended to familiarize the healthcare professionals with the use and the security issues related with the work on medical data. The last point I would like to emphasize is the role of the Health Data Hub at the European level and how we interact with the European institutions on the questions of data. Next slide, please. So the questions raised by data at the European level are basically the same as the ones raised on the national levels. There are lots of sources of data. It's hard to put them together. There are security concerns, but there are solutions, and these solutions mainly, they consist in building joint actions, putting people together, facilitating access, and building networks that facilitate the access. So it's the same questions that led to the creation of the Health Data Hub that are currently leading to the creation of the European Health Data Space. So the Health Data Hub takes part basically in two main points related to European health data. There is the TEDAS joint action that is a joint action focusing on studying the concepts of sharing data at the European level and producing recommendations for the secondary use of healthcare data at the EU level. And then there is a more practical project, which is the proper EHDS pilot, in which we take part as well, which currently includes 10 countries and which has been funded to prefigurate what will be this EHDS. Next slide, please. So concerning the EHDS pilot, the concept is the same, is relying on several national platforms, trying to see how we can put them together and building based on this network of platforms, selecting a few pilot cross-border projects to see how these platforms can work together and deduce some general recommendations from those pilot projects. Next slide, please. So that's how it's going to work. So there are local providers of data. Those local providers of data will work together and build a network of data providers, and we will use this network of data providers to work on pilot projects and then produce some general recommendations for the future of the EHDS. So more precisely, the next slide, please. There are a few pilot projects that are being considered. Here are some examples. So predictive models for cardiovascular diseases, projects related to COVID-19, a project related to digestive cancers, and 3 to 4 pilot projects will be selected, and they will be the projects that will work as projects to experiment how this prefiguration of a health data space can work based on the 10 countries that are taking part in it. Next. And finally, just to conclude some figures, next slide, please. So the Health Data Hub is a new structure. It was created in 2019, but it's increasing every month. We are increasing in size. The number of projects is increasing, and we're employing more and more people. And in 2022, we will work on nearly 100 projects and hopefully make serious progresses in the building of this EHDS pilot and be part of the contribution of France as the president of the presidents of the European Union. Thank you for your attention.
Thanks a lot, Dr. Khonsari. As you know, the organization of the session is that we have now the second presentation, and next we have the questions. And the second presentation will be made by Dr. Johanna Seppänen. I hope she can hear me. And Johanna Seppänen is the director of the Finnish Social and Health Data Permit Authority from FinData. She had the previous positions in the head as the head of statistics at the Statistics Finland Research Services, but also worked as a researcher in the Department of Finnish Cancer Registry, and she has a background in biometrics, and she's going to talk today about FinData. We have a question here, but the question will come after Johanna's presentation. So Johanna, if you're here, the floor is yours. We can see you now, which is already a great advance, but we cannot hear you at the moment. No. Yep. So now it should be okay. Can you try it? No, it's not again. Well, so I'm going to complete the introduction and the presentation from Johanna while the sound is coming. From what I read also, I was quite interested to see that it was not only biometrics that interested Johanna, but quite a number of publications regarding the health of homeless people, which is a field of interest that is very specific. The use of data for health is not only about health, but it's also social, of course, evaluation and assessments. And maybe this is part of the thing Johanna is going to talk about within the context of FinData. Maybe we can try again the sound. I'm quite disappointed because we don't have the sound, but we also lost it. Oh, no, we came back with the seeing of Johanna. Johanna, can you speak again, maybe? No, still not working. Maybe while we are waiting for the sound to come from Johanna, I can just provide with the question that was raised from the presentation from Woman Konsari first, which was, with the central database, how can you guarantee that the database is up to date?
So thank you for this question. It's a really important question. So first of all, the Health Data Hub is not a central database. We have the SNDS, which is a national service in France, and there is the catalog, which is part of the Health Data Hub. But there will be a place for lots of other types of databases in France, and the Health Data Hub is the authority that will federate those databases in the country. But it's not an exclusive national database. So the databases that will be selected to be within the catalog are databases that will be of special interest, of special scientific interest. For instance, let's take the example of a database of 10,000 prostate MRIs. Those databases by themselves, they have a scientific value. So they will be of use for many different types of scientific projects. So, and beyond this, all the databases of hospitals and other types of cohorts will continue to be implemented with the support and the help and maybe the collaboration to obtain funding with the Health Data Hub, but they will be continuously implemented in the country from different sources. But the Health Data Hub itself will have some databases within the catalog that can be implemented, that's possible, but most of the databases in the catalog are selected because they have a scientific value per se, and they're not exclusive to other national databases, for instance, warehouses of the many hospitals we have in France that are implemented day by day by the activity of the hospitals. So it's a dual system and a non-exclusive system. And there is some data that has value without implementation, some data that has no value without implementation. So there is a space for every type of data sources in the country, and the Health Data Hub is only one part of the source of health data in the country. But
thank you for your answer, Dr. Konsari. Maybe we can try, and it was perfectly complete and clear. We can now try to see how the sound goes with Johanna. Let's say it's coming, but it's not here.
I think she hears us.
Yeah, but you can hear us, Johanna. Yes. So that, and we can make some lip reading, but it's quite difficult for a presentation. So, so is there any idea why we cannot have the sound from Johanna? Maybe you can try the phone. This is what you're showing us. I don't know. Why not? We're going to take just maybe 1 more minute to see if the last try from Johanna is working right now. And if not, I will just go with the questions from Roman Konsari, and we will split the question session. Yeah. So maybe. Okay, so yeah. Maybe more reasonable is to make the break now. So 10-minute break so that we can fix everything with the presentation from Johanna Seppänen. And so coming back in at 10:20, maybe, with the presentation from Johanna. Johanna, so sorry for this, and thank you very much for helping with these sound problems. Thank you. Thank you very much for being back, all of you and Johanna. The session is, of course, about data, but it's also about information sharing and linking. So it's a perfect illustration of the difficulty we can face in such exercise. Dr. Seppänen, I already presented you, so floor is yours, and thank you for your presentation.
Okay. Thank you very much, and thank you also for inviting me. Can I have my slides, please? Okay. I'm presenting FinData, which is the Social and Health Data Permit Authority in Finland. We were established, or we started to operate in 2020, so now we have operated a little bit more than a year. I have a short word on the circumstances of secondary use in Finland. Then I have a short word on the legislation you might have heard before. Then I have a couple of slides about the role of FinData. And in the end, I have some figures, statistics from 2021, which was our first operating year. So in Finland, we have had secondary use also before 2019. So our oldest registries tend to 1950s, I think. We have very rich national registries covering almost the whole population, and they are utilized a lot, but a lot of more could be used. So one of our goals is to enhance the use of health data. In Finland, we don't need to have a consent to be able to use, for example, the patient registers from hospitals. So we don't need the consent, but we need a permit from authority. And then that's one of the reasons and one of our tasks in FinData. Can I have the next slide? Now the slides disappeared.
Can you see the slide?
Yeah, okay,
yeah,
thank
great.
you. The legal basis, the Act on Secondary Use of Health and Social Data took effect in 2019. It regulates the secondary use, the research activities, but also statistics, teaching, some authorities, planning duties, development and innovation activities, for example. So it makes clearer rules for also other kinds of secondary use of health data than research. It acts as a constitution for FinData, so it defines that FinData is to be established, and moreover, it gives FinData the authority to grant permissions practically to all the health, but also social data that exists in Finland that accumulates in the everyday healthcare activities. So we are a sort of, could say we are a gatekeeper authority for the Finnish health data. About our status, we are an independent authority in connection with the Finnish Institute for Health and Welfare. About funding, we have budget money, but also we collect the fee from permissions and the data that covers 10-15% of our costs. It's supposed to be more, and we will hope it will be more in the future. Okay, next slide, please. Role of FinData. So what do? We grant permits always when the data comes from multiple controllers. So we collect the data, we link it, pseudonymize it, or anonymize it, depending on the case, and then deliver to the customers for use. We issue permits always when the data is requested from private healthcare units. So you can access data, both the public and private data through FinData, and from the electronic health reports that are called Kanta services in Finland. We also produce statistical level aggregated data that is anonymous when it's issued. So the data security and safety operations are not so strict. One of our tasks is to maintain a secure IT environment for applying data, for transferring data between data controllers and FinData, and also for researchers to analyze it. So we are providing a remote access system called Kapseli for data analysis. We have a help desk for data users, which is very popular. You can ask about the quality, the availability, the interoperability, costs, and so on about health and data, and we are doing our best to answer. If we can't find the answer, we will be asking the data controllers that are the ones that produce the data. We also have anonymization services for you. Next slide, please. Oh, this is a simple illustration about the system. So the researcher sends one application, or it's digital, so leaves one application to FinData, and FinData is then sending the sampling requests to data controllers that are doing the sampling and sending the data back, and FinData will then link it and pseudonymize it. So we are not really a federated operation, but we don't either have a data pool, but we, like for each specific study and purpose, we sample the data from hospitals and national registries and healthcare units and whatever is needed. Next slide, please. We also issue, according to the Secondary Act, we outline and give regulations for the research infrastructure. We have issued a regulation on the security and safety requirements that are needed for secure operating environments. We have issued a regulation outlining the data descriptions and metadata, and we are about to issue the third regulation about the data application components and form, making sure that it's standardized and fulfills the consistency with GDPR. Next slide, please. here you can see the big picture of the database. So the blue square illustrates all the social health data that is collected in everyday healthcare system when Finnish people are visiting healthcare centers, hospitals. They are diagnosed, medicines are prescribed, and all the activities where they collect data from the patients and customers. The prescriptions have been in electronic form since 2017 in Finland, so they are all available. And we also can provide all the data that is electronically collected in social services, but that's not all digital yet. Then we have the national registries. Most important is the Finnish Institute for Health and Welfare that has, I think, 24 different registers, such like cancer registry, malformation registry, hospital patient discharge registry, and so on. So they are used a lot. Then there is the population data agency that provides not really health data, but the important background information for epidemiological and also for other research. We have the Social Insurance Institution, Statistics Finland, Finnish Center for Pensions for pension information, and so on. Then there are the biobanks and genome data that have the legislation still upcoming, but I think the purpose is that in the future we would be also permitting the genome data with the one-stop shop principle. Next slide, please. These are our main products, so you can access individual level data or aggregated data, and we never give out the direct identifiers, so the individual level data will always be pseudonymized and available only in a safe and secure environment. Next slide, please. FinData in figures. I mentioned last year was the first full operation year, so we have fresh statistics. We received a total of 312 applications, and we made 2,062 decisions last year. So most of that was for individual level data, and most of that was for search. So only 6% for the other secondary use purposes. So mainly individual data for research, but also some others. We have all the decisions openly available at our webpage. So if you are interested, you can check. We have the name and the principal name of the study project and the principal investigator. So not very much, but a list of them. About the background of our customers, 66% are from public sector and 29% from private sector, and then there are also something like 5% of our customers who present the third sector societies and so on. So that's the division between the. Actually, we have also many big projects that are a combination of all of these. So there can be university researchers and for example, pharmaceutical industry joining in, and also with some societies. So the strict division to public and private sector customers is not so, perhaps so current anymore. Next slide, please. Here are our top 10 most popular data controllers and the number of applications that we had last year. So each application normally applies for several registers, so these don't sum up. But Finnish Institute for Health and Welfare was the most popular one. Also, the big hospitals are very, the patient data from the big hospitals and university hospitals especially are very, very popular. Next slide, please. Here is the remote access system, update all of it. We have, by the end of the year, we had 52 projects working on the remote access platform. Altogether with 2071 users. I think now we have a little bit more than 60 projects, so this is accumulating quite quickly. The packages are called small, medium, large, and extra large, according to the capacity of computation and memory and so on. So you can choose how much power you need. Next slide. Some statistics about our help desk and comms. We have 3 help desks working on email basis. Our website is very popular also. So next slide, please. I think I'm sorry. I don't know if I'm not. The last slide is about the trust, and it's we go always security and safety first. So we are also supervised by several bodies, Ministry of Social Affairs and Health, and the Data Protection Ombudsman, and also the supervisory authorities. Very important single action for data safety is that we, as I mentioned, we never give out the direct identifiers. So the pseudonymization is a very strong data safety action, and the data is never. You can use the data only in the safe remote access system that is closed from the internet, for example. Our operating environment is also controlled by the security inspections and supervisory authorities. So a lot of actions are taken to ensure that the data is safe and that we are worth for the trust of Finnish citizens to keep them health data safe. I think this was my last slide. Thank you very much. I lost the time if I exceeded it or not. I tried to be quick, but I'm happy to answer any questions if you might have.
Well, thanks a lot, actually, Dr. Seppänen, because you saved a lot of time, and so you saved some room for the questions. We are still running late, of course, so I will try to make them short and efficient. Thanks also for the presentation, very clear of the impressive realizations FinData is, both in terms of content and in terms of use. I would say, having had, as many of us here, to work a lot during the last year on the well, mostly on the pharmacovigilance aspect of the COVID-19 vaccines, and also from what was presented yesterday, what is clear is that pharmacovigilance made an impressive and huge work, and this was very interestingly and importantly complemented and confirmed by pharmacoepi assessments also. And the difference between the two of them is clearly the time of access to the final results of the assessments. And within FinData, so you had a lot of applications, you have a lot of authorizations granted. My question would be, what is the mean time from the application to the access to data?
Very good question. It varies a lot. Now we have with some, it depends on the complexity, on the number of data controllers. So for example, if we receive an application from that needs data from 24 Finnish municipalities, healthcare centers, it will take time. FinData will contact all the healthcare centers and do the sampling requests, and it will take more than half a year. But then if we have more simple requests, like only from the Finnish or some 2 or 3 national registers, it will be quicker. So and it also depends how the customers and the data controllers are providing the additional information we are questioning and so on. But from 3 months to 7 would be the average.
Well, with French eyes, it's quite very nice, I would say, and
Okay.
and to be really soft. but that's really great. You mentioned also that you had electronic prescription till 2017, if I'm right. Does this prescription include the indication?
It includes the diagnosis.
Okay, so yeah, because this is
Okay.
An important information that sometimes lack in other circumstances. I have other questions. First is clearly a question of the regarding the organization of FinData. What are the technical and human resources and the decision-making procedures for the examination and the decisions regarding the applications?
Okay. Resources are scarce. Should be more, but we are now some 25 people organized in data team and in the permit team, but they are flexible. So we have people working on the permits, and we have people working on collecting the data. And then we have the steering group.
Okay.
The computer system or the computer environment we rely on and we operate on is produced by the Scientific Computer Center in Finland. So we are not, we are like buying the environment as a service from them. We are not, we don't have an IT department here at FinData. Okay. We have a head of IT that is coordinating them and leading the things.
Okay, and on the application evaluation?
Application evaluation, we have 5 to 7 people now, plus a lawyer supporting them. That's very important. We have our own lawyer that is available for the staff that is going through the applications. They are amazingly complex sometimes.
Thank you very much. One very last question, and it's a very technical but crucial one. Is how the linkage is done? Is there a defined identifier for each person in the dataset or in Finland?
Each Finnish person, each Finnish citizen has a unique identifier, which is used as a key. So that's it's a very good question. Also, it all originates with the key is making this possible. Without the unique identifier, we wouldn't be able to link the data with in that process we are doing now.
Thank you very much, and thank you for your presentation, your clarity, and for your answers. You mentioned at the end that there were quite a lot of partnerships that were involving public but also private entities, and I'm pretty sure that there is here some room for benchmark and probably for improvement for our French side. So we will certainly solicitate you on that aspect. Thank you very much once again for your intervention.
Thank you.
This is the end of this session, and we will now give the floor to the next moderators and presenters. Thank you very much. There is no more break, so just keep here. Stay.
So good morning, everybody. We will pursue this session number 3 beyond the pharmacovigilance and the pharmacoepidemiology with 4 additional experts. So first, Dr. Jesper Kjær, who will speak about the European Big Data Initiative. Then we will have the real-world evidence in clinical developments presented by Dr. Peter Moll. We will have time then for questions and answers, and please feel free to ask as many questions as you wish, and we will save a dedicated time for this. In the second part, we will have a presentation of Dr. Sylvie Benchetrit about registries and clinical trials in children. And then Professor Gilles Vassal will tell us more about the use of real-life pediatric data in clinical trial design and efficacy data for oncology drug development. So thank you very much, and I let my colleague Patrick Maison presenting Dr. Kjær.
Thank you, Corinne, and hello everyone. I'm very pleased to introduce Jesper Kjær. Jesper is a specialist, an expert in bioinformatics and computer science. He set up and currently heads the Data Analysis Center at the Danish Medicine Agency. And maybe the most important today is the current co-chair of the Big Data Steering Group. His presentation focused on this joint Big Data initiative. And so good morning, Jesper. Thank you for being with us, and the floor is yours.
Thank you. Thank you so much. Really appreciate the opportunity to present here today. So let's just get on with it. So for the slides we are sharing here, you will see that the current work on the Big Data Steering Group is centered around these 11 recommendations. And I have to admit the picture doesn't really come through clear to me here right now. I'm a little bit unsure on what end this sits. But it's important to realize that all of these are complementary in the work we're going to do. And you'll see one of the corner pieces here is the Darwin EU initiative. But leading into this, there are a number of other initiatives that are crucially important for the success of this work, which will all be coming together as puzzles for what we're doing here. Including that will be governance, as you'll see towards the bottom of this. There will be the procedures around this that we are developing. All of that then leading into other activities around the network capability to analyze in point 6. And then I think also need to highlight the work around the development of the data, metadata and the data standards that are also really crucial for the success of this work. Next slide, please. Now, the work schedule is really busy, and I think that's the take-home message you should take from this slide, because I'll not be going into the details of this just to spare you the time. But we have actually initiated a work program that is progressing quite aggressively on all of these 11 initiatives. And happy to say that this is by and large on track as we progress on this. We will, in this presentation today, take a smaller look into some of the areas without really getting lost into details around this, but I'll definitely give you some progress updates. So next slide, please. And on this one, it's worth just remembering that we actually, on the Darwin EU work, are actively pursuing a patient and healthcare representativeness in the advisory board. And I'm saying this because it's probably part of our discussion later on in the roundtable. We also involve both healthcare professionals and patients in our raw data analysis advisory board at these meetings too, and we'll get to some details on that. We have launched and have it endorsed by the EMA Management Board, the regulatory network data standardization strategy. So starting to harmonize how we look at data. We're going to expect data in what form and structure. There has been a selection of a consortium now to also drive the EU data quality framework, leading to recommendations and processes around data quality. And you'll see a number of initiatives over the next coming months that will cover areas of this. The Darwin EU Coordination Centre tender was completed end of last year, and it was the Erasmus University with the consortium selected for driving this very important initiative on Darwin EU. We'll have a deeper dive in a minute around 2 stakeholder workshops that we have organized. The Learnings Initiative for Optimal Use of Big Data for Regulatory Purpose, and a multi-stakeholder big data forum that we'll just cover in the next slide. The feedback from these workshops, obviously, we are very, very focused on integrating this into the work plan and our activities. So we do actually adapt the input and our processes accordingly as we involve in these discussions. Then there's also continued focus on patient-reported outcomes. So work here being initiated around involving, including that in our processes and our use of data. And there's a workshop coming up early summer this year around the topic. A general report on the Big Data Steering Group is in preparation, soon to be launched, but we just recently also launched a newsletter, which I'll just encourage you to sign up and subscribe for that if you want to be continuously informed about our initiatives. That may be probably the most relevant way to stay informed. Now let's go to the next slide, because I think I'd just like to take you through some of the learnings we made from our 2 stakeholder workshops. And I appreciate this is busy. You need to see this in the 2 buckets of the Learnings Initiative and the Stakeholder Forum. In the Learnings Initiative, in end of November, we actually discussed the fitness of real-world data for regulatory purpose and how that should be integrated in the process of generating that real-world evidence. And one of the key items that came up here, and that's why we hear us talk about data quality, is the data quality and validation that really builds the foundation for the scientific evidence, the robustness, the trustworthiness, the reliability in this data and the use of it. Now, we also had very clear input on that the scope of stakeholders involved in developing the area should be broadened to data providers, healthcare systems, and policymakers. Again, it's a question about what generates the data ultimately affects the evidence that can be used at the end. There has been issued, and it was also discussed here, the recommendations from registry-based guideline. broadly should be applicable to real-world evidence in general, regardless of what source of real-world evidence or data we talk about. Then that should be the North Star in the way we approach this, both for pre and post licensing real-world evidence generation. A clear identification we've had actually quite early on in the process is the skills necessary for analyzing big data. Is actually part of the work program to develop the skills within the regulatory network. So it's high on the agenda to develop the curricula to enable the regulatory agencies to better make use of real-world evidence and analytics in general. But we also had some discussions about whether we should probably broaden this a bit also to target patients as well. But we'll see that in the other recommendation. Then one important piece that was highlighted in the Learnings Initiative is there's heterogeneity between the results as we see them across Europe, and we need to distinguish between heterogeneity, as we call that, as desirable, because it really tells us about the treatment differences, the practices, the actual implementation of using drugs and medical devices. Take that apart from data quality issues and so forth. So again, here some metadata is needed in order for us to better to understand, decide and undecide heterogeneity in results. The following workshop we had in early December was a revalidation of the priorities you saw on one of the earlier slides. And from our participants, including academia, industry, other regulators, patient representatives and healthcare professionals, it was actually highlighted in this order that data quality and representativeness was the most important work, followed by the establishment of the Darwin EU, and then looking at the regulatory processes. And I think you would appreciate that equally internally from the regulatory agencies as you would from industry. Now, there was also a clear steering here that we need to engage with and align with the rare disease areas and the reference networks, and really establish a place for patient-reported outcomes in some of these areas as well, and make use of that data just to give a very strong voice to some of these either neglected areas or include the patient voice in the work we are pursuing to do. Then transparency came up. Transparency on the process, on the methods and the results, and they came from all across. Also giving the clarity and regulatory requirements on the data quality. So once we get to it, make it very, very clear what it is we are expecting. And then further strengthen that clarity and communication through guidelines and guidance, best practices and tools kits wherever we can. Back to the skills of actually lifting this activity, it was very clear from the discussions we had that we want to look at skills beyond the regulatory skills. To me, that goes very well hand in hand with concept about health data literacy, our ability as citizens, as democratic citizens in Europe to understand our own healthcare data and how this is being used and what altruistic purpose it can serve. Also when you need to be careful about how you share your data. Pilots, results and lessons learned. We should probably discuss those more broadly with stakeholders. So point taken on that. More research on methodologies needed. I think we're still, honestly speaking, in the regulatory context, struggling a bit with some of the new developments and really curious and interested in learning and adopting these. And then a very important piece that easily can be overlooked as you build something across the member states in EU. None of this really works in the region of EU alone. It actually is international. So be mindful about international convergence around these things as well. So also something from the feedback we got. Next slide, please. So the future highlights for 22 is just, and I think I want to spend a little bit of time on this just to let you know what is coming already. The coordination center I told you for the Darwin EU has been launched, and I think the preparations for the pilots are actually well underway, and we'll get to see a bit about that in a moment. The EU data quality framework will be made available. So there's actually a workshop coming up in a few weeks' time, but we'll share more about that through our channels. Agreement on real-world metadata for regulatory purposes, again coming to what information do we need about the data, and the launch of the real-world data public catalog, really supporting a better transparency on what data sources are available for what purposes. There will be progression on the development and the rollout of the big data curricula on biostatistics, pharmacoepidemiology, and data science. So the training delivery provider has been selected, and now the training will actually be initiated. We'll see in a bit that the EU network processes, being mindful about all the EMA committees actually made up of member states representatives. So this is really the network processes to support real-world evidence integration with pilots into the different committees. And I'll show you in a bit what that looks like. But it's really an important piece for this year's work. Then further establishing and strengthening the member states' ability to analyze data. We've actually been discussing our clusters of excellence approach, and we'll take a month or two before we can share that publicly, but it's really bringing member state competences together to further support data analytics across the EU space. There's work also here on draft and guideline on AI in medicines regulations. There's actually quite a lot of interest around AI in many of the regulatory agencies as well. Delivery of expert advice, building the roadmap for real-world guidance, real-world evidence guidance, and how that can actually be part of the expert advice that we will be able to offer either on central or national scientific advice. European health data space, aligning with that, and the governance piece here is important that we are taking stock of that. EMA is involved in the ESGS2 pilot as well, and some of the use cases are of high relevance, obviously, for the regulatory area. Then real-world evidence international collaboration roadmap, again here being mindful about the international perspective, reaching out to the other agencies, whether that's FDA, Health Canada, and so forth, just making absolutely sure that we are getting aligned on these areas. Again, coming up with multi-stakeholder forum on big data, it's a really, really good chance for everyone to recalibrate priorities at these meetings, so that will be coming. And then there's development, really interesting development within the veterinary medicines area of establishing a vet data hub, but I'll not be covering that today, unfortunately. So I'd just like to bring your attention to some of the Darwin EU initiatives. So next slide, please. So just wanted to, again, re-emphasize that there was a tender process last year from June until the end of the year, in which several rounds shortlisted 3 candidates based on technical and professional capacity. That was completed by August, and then the 3 remaining candidates then submitted their final offer and were invited for negotiations in November and into December. And these final offers were then evaluated by the evaluation committee. And I think this is actually a little bit outdated slide, but as I said, it is Erasmus who has been appointed to run the network. Next slide, please. So what has happened in the more recent time that you've been able to follow is there's been a press release about the announcement, targeted emails to stakeholders, and written into you with media outlet as well. So you've been able to follow that a bit. Multi-stakeholder public webinar was held only a week or 2 weeks ago, showcasing what the initial work will be all around. And then obviously the newsletters that I just alluded to also talk about the work. Next slide, please. So the ongoing activities in this area now is that there was this kickoff meeting, and there's a twice weekly meeting with EMA and Coordination Center, really just to get this underway. And EMA will oversee the deliverables and monitor the performance around and of the different metrics of successful implementation of this. And we'll just have a look at that on the next slide, so you have a sense of what is actually happening in the space. So next slide, please. So these phased deliverables, there's the general formation of the coordination center. Now, with the reality of Erasmus being a really experienced entity in this phase, this is actually, as far as I'm aware, progressing really nicely. So the project management plan and the establishment and everything is well underway. Over the next 6 months, there's the work to strengthening the coordination center through the solution design, the conflict of interest management process, and the establishment of a scientific panel alongside with that, and the change management plan. Again, being mindful about we're introducing something new in the regulatory network in Europe. Pursuing, again, also strategic oversight of coordination center, onboarding of data sources, developing the templates on this. Erasmus has experience from other networks that have been successfully operating to onboard a wide range of data partners and data sources. So obviously there's a lot of experience in doing so, and really looking forward to this being successful in the Darwin EU network. And then obviously developing the studies templates, so there will be a very transparent and smooth process from requirement for an analysis to it actually being able to be executed. And then the first studies will expectedly start in roughly 6 months from now at latest, maybe even earlier. Let's see. Next slide, please. Now, why is this really important? It's important because we can see that real-world evidence is actually something that we can benefit from in many of the committees across the EMA work. So here's the overview of the evidence pilots that are being foreseen. It's not a surprise, obviously, that within the PARC area, there's experience already, because it's part of the safety surveillance process is already today that a lot of real-world evidence is being used to understand a problem. But there's also pilots that will be made through the SAOP, the Scientific Advice Working Party, on the different other committees, including as well, more interestingly, the CHMP, to make sure that that is being part of it. And then we are highlighting here that the national competent authorities should actually be able to use the network, the Darwin EU network, for their specific requests. But all of that needs to be mapped out as we progress on this. And then you can see that being mindful about the HTAs and the payers and the European Health Data Space 2 secondary use pilot also aligning with that. So a lot of activities going on in that. Next slide, please. So coming to the NCA piece, and that's where we are seeing this as an opportunity amongst the member states, that the NCAs could potentially, as we start to really embrace real-world evidence in our work, use this to be able to use the Darwin EU for our public health questions. Is effectively a lowering of a technology barrier to analyze data. That's a really great opportunity. NCAs will also join the Darwin EU network of stakeholders. That needs to be sorted out, but it's not uncommon that data is associated with a number of national competent authorities across Europe. Without going into the details of this, this could be really important to enable that through the network. And then obviously in the future, NCAs would in the committees be utilizing real-world evidence results from Darwin EU. So obviously it's critically important that it's being built into the way we operate and the way we work. So very interesting changes ahead of us in the regulatory landscape for the years to come. Next slide, please. So a different area that I wanted to highlight here, and it's not to do with real-world evidence, but it's the other kind of a pillar you need to stand on if you want to do data analytics. And it's the raw data pilot. Raw data pilot here means that it's patient-level data from the clinical trials, where a pilot here will inform us about how we can actually use that and the technology and the processes that potentially will improve our market authorization approval process in the future. Next slide, please. So it's really embedded into a strategy, the network strategy. So it's enabling the access and the analysis of not only the healthcare data, but also the patient level data from clinical trials. And the pilots we're going to initiate is really to understand how can we make this work into the process we have, the way we operate in Europe, being mindful about that using this data has been done in US FDA and PMDA for the past 7-8 years by now, and it's also mandatory for approval to submit that data. Next slide, please. I just wanted to share with you a little bit that we've actually had this coming a long time. It's actually been discussed and evaluated previously within EMA if we wanted to do this, but it wasn't really the right time. So there were a few considerations that had to be made with the CHMP in terms of what can this truly mean to us. And that actually led to some reflections over the years. I think we need to be mindful about that other events happened alongside, meaning why this did take the amount of time it did. But now we actually through with the network strategy that supports the direction, that really wants to explore the value and the benefit in this of how the randomized clinical trials can actually also support our approval process. Next slide, please. So determine the benefit. I think that is, and also how that it's will be used in the way we are going to operate. Understand and take informed decisions in the network, and how this can play a role in future regulatory submissions. Definitely need to put in place procedures and safeguards the process around clinical trial data as we are to receive it. We have established an advisory group on raw data that, based out of some of the existing pilots that have happened, both at EMEA and at some of the agencies, the national agencies, will inform and discuss the direction of this important work. Then ultimately performing the pilots and then through stakeholder engagement and a communication plan, make sure that we actually get it truly and rightly embedded on the pieces that we identify are value adding in our process. So nothing concretely decided yet, but the pilots are there to inform us. Next slide, please. And I just wanted to highlight to you that the process we're looking at right now, it's accelerated since end of last year to design and prepare the pilots, develop the business processes, design an operating model, which is now at this point in time is leading towards preparing for an estimated start of the pilots here in point 2 in June this year. And for a duration of 9 months, we do expect that these pilots will be ongoing. We expect there'll be 10 of them that will be chosen on predefined selection criteria. Obviously, on the willingness of the applicants to take part while letters of intent. And then there will be different operating models we need to explore for this, because there will also be different purposes, different value creations that can create, whether that's all the way from the initial CMC review to sensitivity analysis, to revalidate, to unusual signals in the data, but also to inform inspections for GCP auditors. So that will then, through these pilots, lead to a key decision point in early 23 to make recommendations out of the pilots to the CHMP from the Big Data Steering Group and the heads of medicine agencies heads on the regulatory benefit from accessing this raw data. So really interesting and important work coming here that will also be very relevant for data analytics across Europe, not only with real-world evidence, but also the RCT trial data. Next slide, please. So just finishing up on this one, just saying that, I mean, across the 11 initiatives, there's actually been significant progress in 2021 on the data transformation of the EU regulatory network. We are very much aware that there's a long way to go, but the initiatives to support this development are progressing really nicely, and especially with establishment of Darwin EU and the pilot and clinical trial raw data analysis, as I just shared with you, this will further be enhanced. And that's where we effectively move from talking about data analytics to actually doing it, which is obviously what needs to be very high on the agenda. I think I'll probably just close the presentation now. Thank you for listening.
For this very interesting presentation. I'm sure that we will have many questions. So as previously said, we will take them at the end of the first part of this session. But thank you again. So now we will welcome Dr. Peter Mol. Is Mr. Mol available? Okay. Good morning, Mr. Mol. We are very pleased to welcome you. So as PhD PharmD, you are also Senior Advisor at the Dutch Medicines Evaluation Board and the Vice Chair of the EMA's Scientific Advice Working Party. Dr. Mol is a Professor of Drug Regulatory Science at the University Medical Center Groningen in the Netherlands. Is currently involved in many projects, including personalized medicine, new data sources, such as real-world evidence, so that Mr. Mol is definitely a key actor in this conference. And I give you the floor right now, if you wish. Thank you.
Thank you. Thank you for the invitation to be speaking at this very interesting conference. Unfortunately, it collides with the Scientific Advice Working Party work, where obviously in the regulatory world we have the first interaction on new developments of drugs, and also the application of real-world evidence in, let's say, the setting before licensing. So perhaps I could get my first slide, please. Yeah. Super. So I would like to start out with the context on what we will be talking today, and I've expanded my title a little bit to talk also indeed in the relationship of clinical development and medicines regulation. Next slide, please. So where we are very comfortable with in the regulatory field is obviously having two double-blind randomized controlled trials telling us exactly what the drug does in efficacy and in harms, and then we balance it out for making a decision on approving or not. Next slide. Clearly that would be great, but this figure indicates if you follow the blue line, if you generate more evidence, more data, you will avoid making wrong decisions. But if you follow then the purple line, you would see that there is an optimum to this. If you keep on collecting data, you will be keeping on postponing approvals of medicines, and that would be obviously detrimental to public health. Next slide. And very important, and I apologize for the Dutch title, I just realized it, changed it this morning, but that's to no avail because I have already submitted my slides. In the approval of medicines, the playing field is changing. We see different therapeutic areas where 10 years, 20 years ago, we were talking primarily about cardiovascular medicines. We are moving towards cancer therapies and other areas where we see many developments. Next slide. Also the designs of the trials, we are getting more and more away from that to clinical trials, and we are moving towards single pivotal trials supporting an application. Next slide.
If we may have the next slide, please.
I'm sorry.
It's working.
No problem. You're welcome again. You can go ahead.
So okay, yeah. So I'm saying was saying that also the trial type of designs are changing. We are getting more single pivotal trials in an application. If I get the next slide, please.
Next slide, please. For Dr. Mol.
Okay, so.
Sorry for this inconvenience. We may solve it very soon. Could we have the next slide, please? Okay, that's fine.
Okay, I don't see it. My screen is frozen seemingly, but okay.
We can see it.
Okay, you can see it, which is okay. So the next slide would be showing that we do get real-world data to support applications, but that often the data aren't really sufficient. The little blue dotted line in the horizontal dotted line would indicate how much data we would need. If you press again, I will have a slide that shows you also other aspects that are being discussed often in, do we really need to understand the added therapeutic benefit? And that is a commentary where we as regulators still have to stay away a little bit. We weigh drugs individually, and then the field can really choose between those drugs. If I get the next slide again, it is about old questions that are always there around the representativeness of randomized controlled trials. It is getting a little complex if I can't see, if you see my slides.
No, please go ahead. Please speak, and we will, push the slides accordingly. No problem.
So this is slide 9, and one important aspect that we are missing is the representativeness of trials. If you push again, this is a comparison that was made for cardiovascular outcomes trials for diabetes drugs. 4 different drugs, compare the major outcome trials being compared to a real-world data set of about 800,000 patients to compare how representative these trials were. And if you click again, what you see is the blue areas in the circles are how well representative these trials were. And actually, if you see that, it is really a very big difference between some of the trials that had around 17% of the population represented from the real world practice, whereas some had over half, but that is really indicating there is still an issue there. And if you're not yet convinced, if you press once more, aducanumab, the drug to treat Alzheimer's disease, not approved in Europe, but recently approved by the US FDA. Here, what you see is that the exclusion criteria applied to in the trial, the different ones, were looked for in a real world data set again. And then you see that for some of these exclusion criteria, up to 60% of the patients had such an exclusion criteria. And if you click again, you see that up to 40% of the population in that real world would have more than 4 exclusion criteria applying to him or her. So really making these trials very unrepresentative of the general population. So if I click again, this is a picture from IMI Get Real, a group looking at where can you do or improve real world studies. And they have really shown this very interesting picture where we feel very comfortable with the orange dash or arrow indicating that post-marketing use of real world evidence. But in the meantime, we are also seeing the application or the interest for using these kind of data to inform new trials, to inform new populations, and also maybe manufacturing changes and many other aspects where these types of data could be used. So if I get the next slide again, I'll talk a little bit on some recent reviews of the use of real-world evidence in marketing authorization applications. So that is the current situation. And if I go to the next slide, you will see a picture that the previous speaker, Jesper Kjær, presented a lot about the big data task force and the plans that are also there in the European agency and the EMRN network on promoting the use of high quality real world data in decision making in 2025. And so I will be presenting, so next slide please, the first of 3 reviews that have been performed on use of real world data in the setting of marketing applications. This one was performed by the EMA itself, and what they actually showed, next slide, is that in about a quarter of all the applications, no, sorry, I missed it, in about 40% of the applications, there is a use of real-world data. And that is for the extension of the indication. As the lower bar, it's about in 28 of the 125, so a smaller proportion of applications. If I go to the next slide, this is a review also of European applications performed by an external group from the University Utrecht and FPA, where they looked slightly differently at applications and data to find signatures, as they called it, of potential use of real-world evidence in the marketing authorization applications. They next slide. This paper of Eskela used then a sort of flow chart to really put the use of real-world data in various components of the drug development and the life cycle of the drug. And so it's in the discovery phase where they say, well, about all programs refer to somehow the use of real-world data, for instance, to sketch how many of these patients have a certain type of disease and what is coming from the real world data. And so you see that in the development and the early development, the uses are relatively low in marketing access, up to 45% already, and finally to mention practice up to 100%. If I go to the next slide, that is then a review of the same type of work done by the FDA, where they actually stated that in 2019 already half of all applications had some part of real-world evidence in there. On the right-hand side of the figure, you can see different disease areas, and the different blobs indicate, the highest blob indicates how often a drug was approved. The orange one indicates there was some real-world evidence in it, and the purple blob then indicates that that the real-world evidence also really played a role in decision-making. If I go to my next slide, this is an overview of those three studies that have been performed, and where basically the papers indicate that 40, 100 or 85% of applications actually included some sort of real-world evidence. So, next slide, please. Then we wonder, obviously, does it really contribute also in the European context? So we have seen that the FDA, the actual contribution to the discussion, it was lower than obviously all the data submitted there. And my PhD student is currently doing an internship at the EMA and looking there on, can we really understand what the data contributed? So if I go to the next slide, this is a sample of the real-world evidence to support efficacy and effectiveness. On the left-hand side, the data for the marketing authorization application. On the right-hand side, the extension of indications. And this is building on the work of Flynn, so the earlier EMA study I presented, where we are particularly interested in the support for efficacy. And in 31 marketing authorizations, 31 studies were in marketing authorizations proposed, 15 in the setting of the extension of the indications. If I get to the next slide, that was, in the end, it was for 31 products, but 4 of them, the data didn't really play a major role. So we are left with 27 marketing authorization products, where in 15 cases, and there I will focus on, it was in the setting of pre-authorization real-world evidence. For 7 authorized products, 6 withdrawn and 2 refused ones. I won't talk about the extension of indications. These are preliminary data. Next slide. So of these 15 products, they are 10 really talking about efficacy and safety data collection. 5 are more in contextualization, so the natural history of the disease. And of these, actually 7 products were not really adequate for decision making. It's written in the reports. 4 actually didn't even address that data in the discussions in the European Public Assessment reports or in the, and 4 products there, the data was really considered contributory to the decision making or supportive or critical. Next slide. And two of these examples I wanted to give. One is Cufence, a treatment for Wilson's disease, is a copper stapling disease, and where the data were a multi-center retrospective study, and that was considered important and sufficient by the CHMP, considering that this was already a known active substance. So we had already some understanding of the drug, and that the protocol had been given to the SOP and Scientific Advice Working Party for input, and that the protocol had already been agreed. There were some limitations, though, with the real-world data, sample size, chosen endpoints, and potential of bias. So there was the question of a further post-authorization efficacy study to be performed. Next, Zolgensma, a drug, so that's the next slide, for treatment of spinal muscular atrophy. Here, two databases supported the natural history of the disease. And if I get the next slide, the comments of CHMP and SOLP, so the scientific advice before approval, said, well, we would prefer an internal comparator, and some form of control would be necessary in the trial, but historical controls could be adequate if bias is going to be minimized. CHMP, when looking at the data, then said, okay, the historical controls would be adequate. One cohort, they had a problem with patients with less severe disease because they were older, but that wasn't considered a major issue because that would have given that gives a bias against the product, because these patients would show a better outcome, and so it would be a higher hurdle to overcome. So in this case, it was considered important. If I get the next slide, the conclusion would then be that there is an increasing use of real-world evidence in marketing authorization applications, primarily in the setting of oncology, immunosuppressive, and anti-infectives. And it is still work in progress to really define the value. So now I will come to the final part of my presentation. Next slide. So what do we now really do in regulatory science, and the Scientific Advice Working Party I always call applied regulatory science. Next slide gives some of the activities. Obviously, Jesper Kjær presented very well what the big data task force does, but I think also smaller types of real-world data, the registry-based studies, the registries supporting various parts of the application. I see my slides coming back. Are very key to the decision-making. And we've already spoken about the registry-based study guidelines. So next slide. Here, no, my screen becomes blue again. In this slide, if you can see that, it is around the types of examples where we see proposals that can be in the rare disease setting to extend indications, comparative effectiveness studies perhaps proposed, and for instance in oncology, where in some cases we even seen examples that the RCT was proven to be negative, and where real-world data was proposed to contrast that, because the RCT was performed in a setting in Japan, and which was not considered really relevant for our setting. We sometimes see, and I'm not sure if people see my slides. Can I get a sign that we have? Yeah. Okay, good. I'll just go on. In the setting of cardiovascular disease, large pragmatic trials being performed or suggested by companies, where we actually told the company, well, you're probably too early with that. We think there's a lot more monitoring necessary with the development, so rather perform a traditional RCT. I think it depends very much on the stage of the disease. So these are a couple of examples, and I won't go through all of them. You can read the slides back later if you like. So next slide, please. This is what I always show first-year students, still, well, groups like you, very experienced, obviously, in medicines development, that this is why we want to have RCTs, because these patients who we want to study is obviously very important, but we want to know what the drug does, and we want to take the patient factors as much away by using this randomization part and eliminate patient and non-drug specific factors out of that to really understand what the drug does in terms of clinical outcomes. Next slide. And clearly, this is something that is also a very big issue and a known issue, and I'm pretty sure you have discussed it, where we have seen real-world data studies really giving you the wrong outcomes. The hormone replacement therapy was seen as a very beneficial kind of treatment. Cardiovascular outcomes would be very great, and it was based on a nurses' health study where relatively healthy people were enrolled in the trial, and for that reason they saw a lower risk of coronary heart disease, which couldn't be replicated in trial data. Contrary to that, in digoxin, another drug used in cardiovascular spectrum, actually the opposite was seen. This drug is relegated to a sort of last line use. Patients are more sick, and with that there was a higher mortality associated from the real world data with with clinical trial data ultimately was obtained. And so that really gives you an indication that these risks of confounding are obviously very important, and we can measure some parts of the confounding, but other ones also not, we cannot. And therefore it is important that we always consider how to deal with that. Next slide, please. And there we have all these fantastic kind of analytical tools, which we really can use to try and improve the understanding of the data. Next slide. But important from the regulator perspective is that we first have a question that is going to be asked, and questions are here on the screen, but they're not, we have done and performed a study, and with that we come to the regulator telling you this is the outcome. You need to have that really pre-planned. Next slide. And what I am very enthusiastic about is that we probably will see these registry-based randomized trials or registries forming the platform for starting to perform new trials. So we follow patients already in time, we identify them before the trials are being performed. Next slide. And this is indicating then a little bit on the real world evidence and me. You indicated I'm doing lots of things. I'm really interested in these registries. I had a PhD student working on that, and we'll come back to that in a minute. Obviously, I refer to my student who's looking where real world evidence fits in decision making, especially in relation to personalized care. Artificial intelligence, machine learning to use and get additional data. And I think the work we do at nationally in, for instance, trying to set up disease registries for novel and expensive therapies is something that is really important, and the EMA Patient Registry Initiative I mentioned. On the right-hand side here, you see different application places, and if you click once more on the slides, you will see that you can, sorry, can you go to the next slide? We can have also additional data coming into that data set. And if you click again, I think what is also important is that with the advent of the real world data, we will be able to maybe make our decisions at different stages with more uncertainty at time of an initial approval and sort of, well, what we now know more call the conditional approvals, but which was called the adaptive pathways, to have the real world data complement the clinical trials data based on which we have approved the medicine. Next slide, please. And I think this is important work that we've done with Carla Jonker, who's now working both at the Dutch Medicines Evaluation Board and the EMA, but where it is really important to understand that real world data and registries can provide that kind of data, but it depends very much on the cycle of the life cycle stage of the drug, what type of data are needed, and how this is going to be analyzed. So that is what this picture wants to envision or give or present. Sorry, will present. And if I go to the next slide, I think what is also important, Jesper Kjær mentions a number of training exercises that there are, And I also indicate that there are different ways of how you can analyze data. I think one of the important aspects, and many of us are probably working here, maybe people attending the meeting also, on seeing how we can start improving our knowledge on how to handle these data and how that is going to be integrated in regulatory and HTA decision making. And this is, I think, a large impetus for new knowledge being generated, but also being adopted by us. So then I'll come to the real final part. Next slide, please. And next once more. My take-home messages. So yes, I think by 2025, what Peter Arlett and Jesper, Carl and Ima Cook said is really, I think we will have by 2025 a more established use of real-world evidence. Next slide. No, it will not be a magical wand. It will not solve all the issues. The stones on the right-hand side indicate all the different types of levels of evidence we need to understand the use of a drug, coming partly from trials, but also with additional data from modeling, but also from real-world evidence. Next slide. We are working on the way how to guide that. Different guidance documents are given here by the group of Nancy Dreyer, where they really presented a lot of the guidances already in place from different countries. And if I go to the next slide. This is really my final slide. I think that the current contribution to decision making actually is still limited. You really have to realize that the RCT is really the cornerstone of what we do, but real world data and real world evidence will be important complementary material. It will provide you a very good understanding of natural history and could be also used as an external control. That is a higher hurdle, but that is especially for the very rare diseases in the settings of, for instance, gene therapies, where I can really see that role. Patient registries will also increasingly, in my mind, be used to be the platform for trials to be performed, or to augment RCT data by looking, okay, what is the representativity of this population in the trial for the real world, and what can we expect and how that works. If we randomize patients within those registries, we get towards the RRCTs, and I think that's another interesting development for the future. But always be careful of the bias. If you don't randomize, this will be a major issue. And clearly, while our knowledge and experience is growing as regulators, it is not yet complete, and I think having early interaction with regulators is really key. And so scientific advice nationally or at the European level is really recommended if you want to do this. And I think that the new tools to strengthen the real-world evidence, AI, ML, federated learning, all kind of aspects will help us in getting better data. So thank you. And on the next slide are the people who helped me a bit with preparing these slides. Thank you.
Thank you very much, Peter Moore. Thank you for your very clear presentation. And stay with us, because if I understand well, we lost Jesper for this Q&A session. So, Peter, your presentation is very clear. It's a clear overview of where we are and where we come from, and even the future. But even if safety remains the main objective of real-world studies, you observe an increase use for efficacy, effectiveness, and effectiveness in specific populations, such as rare disease. But what do you think about the next steps? Should we expect other objectives, or remain with the same proportion between disease goals? Your microphone.
Sorry about that. I'll expect to see more of real-world evidence coming into different programs. Primarily, I think, in the areas where we have very rare diseases, we see obviously, especially great developments in the areas of gene therapies, very targeted therapies where patient numbers will be small. So there, I think we want to complement that, especially also because of the controls are sometimes difficult due to issues around the large effects of the drugs. So it's perhaps considered unethical to have a real control. I get lots of background noise. So that is one aspect. The other is, I think, because of our better techniques in dealing with the bias, we will also be opening up to using these data in a more comparative kind of studies, and also in larger disease areas where after, especially in the setting of later stage developments, for instance, in the diabetes, where you have now these large trials looking at cardiovascular outcomes. Actually, we aren't so interested in generating all kind of additional data from these trials. We want to have a simple trial, and we've seen that, like with the recovery and the study on dexamethasone in the COVID setting, where a very simple trial was performed with focusing on the key outcomes. And I think that is a possibility of having these registry-based randomized trials where you really look at main outcomes, but you have to have a good understanding already of the drug. So I expect across the board to see more kind of real-world evidence coming through in our regulatory world, and I think also for HTAs, definitely.
Okay, thank you very much, Peter Moll, for being with us and for your presentation and this answer. I think we have to go directly to the next presentation. So I'm very pleased to introduce my colleague, Sylvie Benchetrit. Sylvie is a doctor in pharmacy with a background in public health and epidemiology. And since 2011, she's the pediatric referent for the ANSM. She's in charge of the National Pediatrics Working Group of Experts. And at the European level, she is the French delegate for the Pediatric Committee for the European Medicine Agency. Good morning, Sylvie, and thanks again, Sylvie, for your presentation on the French initiative in pediatrics concerning registries and clinical trials. Sylvie, the floor is yours.
Thank you very much, Patrick, and I will be very pleased to present the specificities on pediatrics in which real-world evidence is very, very important, but since the beginning in 2007. Could I have the next slide, please? That is, thank you. What I would like to highlight is that since the beginning, epidemiology with incidence and prevalence data has played a major role for the grounds to do not develop what we call the waiver in different age subsets or for a full waiver, but also to understand how the development can be carried out in children by age and weight subsets. That is, it has been enlarged to relevant indication because real-world evidence could provide information on different phenotypes. In particular, in orphan disease, they are very heterogeneous. Also, they provide information for the design of clinical trials. So here we are in the pre-setting information to build the clinical trials with inclusion and criteria, endpoint, and duration. Duration without real-world evidence is quite impossible because some of them are very prolonged. And also then draw the pediatric investigation plan covering all ages and unmet medical need with optimization allowing to use the concept of extrapolation and modeling and simulation tools. Finally, I will complete some words with thanks to Peter about the use of EMA concept paper on real-world evidence, including registries. Next slide, please. So here, one of the 3 examples I will use is in epilepsy. Epilepsy is a complex disease. You have several syndromes and types. And in the most frequent, which is the partial onset, also called focal, it was seen that with few randomized clinical trials, but also with real-world evidence, the similar clinical expression may be acceptable as compared to the adult one, what is stated clearly in the guidelines. However, below, there was a problem to need more data from clinical studies, which render the development quite difficult and postponed. In addition, neonatal seizures, but related to real-world evidence, was distinguished. So the waiver in this case is below 1 month of age. And together with the marketing authorization on this indication granted from 2 years, from 4 years and onwards, but excluding the youngest because there is these difficulties on the neurodevelopmental outcome. The thing is that therefore we don't have labeling for them, and there is off-label use with the difficulties added to ethical and practical concerns and the availability of the data. US FDA has selected a more practical approach and granted indication from 1 month of age. And in the next slide, the real-world evidence data were used by the expert consortium, which is called PEACE, to publish a review on data from clinical studies, but also on disease and the veneer of this patient when they use this drug to say, well, it is the same from 2 years and onwards, and only PK and safety investigation could be done. If we go further for registries that could be prospective and better use, perhaps then we will clarify this issue. Next slide. The second example is about Zolgensma that we have been discussed before by my colleagues, Peter Moore, is about the importance of registries in this expensive drug, but complex. This is for gene therapy for neuromuscular disease, is a spinal muscular atrophy, and in there you have almost 4 types. The most severe is type 1, in where this indication has been granted for this drug, but also for up to 3 SMN2 copies. In fact, before to obtain the marketing authorization, there was a submission of a pediatric investigation plan accepted by the PEDCO in different populations, because we have the aim to cover all the different populations from birth to less than 18 years, which then prone different heterogeneous disease. With 2 registries from Weizmann and Coluccio in Europe, we finalized the endpoints, the inclusion criteria, and also the duration, which are very, very different depending on these phenotypes. The limits of that is that for presymptomatic and milder phenotypes, it could be very, very difficult to build a randomized clinical study. Then prospective and recent registries will be more and more needed if we want to cover the entire population and avoiding the off-label use, and decide where is clearly the benefit risk. There is, in addition, treatment armamentarium progressing a lot in this disease. Next slide. In this slide, we can see that the orange line shaped is on the natural history, and you see a decline of these children on the multiple endpoints on the COP intent at 2 years, while when increasing the dose, there is a great stabilization for these children that without the treatment would not evolve at all like that. In the next slide, the pivotal on type 1, the previous one was exploratory. In the pivotal, the endpoints then were stated like it is in the PIP. And we can see that based on the natural history, has contextualized the external control that was evident that these patients could sit down without support, whatever the score selected Bayes or WHO. Next slide. So the indication was granted. However, in advanced SMA, from there are quoted notes from the SMPC. While it is known that earlier treatment results in potential higher benefits, the degree of burden disease at the time of treatment, if it is too late, then the benefit risk could not be ensured. For that, we will need more registry, and HASEI is a life cycle. At the beginning, we need registries to define, and at the end, to better define not only the safety, but also the efficacy. In the next slide, the result of that is that in the risk management plan, there was the obligation to post-authorization efficacy study set up to contextualize the outcome of patients, and the efficacy and long-term safety also of the drug, to know what will be the extended indication, which is ongoing, is a conditional marketing authorization. Next slide. For the last example, it is on antibody, monoclonal antibody anti-C5. It is ravulizumab. Ravulizumab has a particularity to be derived from eculizumab and could target different diseases. It was here developed in the pediatric subset for 2 different diseases, which in fact are not at all the same in pediatrics. One is on paroxysmal nocturnal hemoglobinuria, where there are many adolescents, and another one of atypical hemolytic uremic syndrome, in where there is a lot of young children. So the aim was to compile both and to target the applicant to say you should be proposed concomitant development to cover the entire subset and to avoid off-label use. In addition, you could switch from previous compounds because there was only a dozen of adolescents and few patients, almost in existence, above 2 years of age, and of different phenotypes, in fact, not the same. Next slide. Thank you very much. The result on that is that it has been completed by extrapolation with the aim to understand uncertainties and to answer of that, and also about modeling simulation population, PK and PD, to optimize a few patients with the blood sampling possible to collect. So it was planned, and after confirmed the dose regimen. The result of that is that you can observe that the dose regimens were quite specific, detailed, accurate, with loading and maintenance dose clearly defined, and even the dosing interval shortened, but only in the last younger subset because of increased clearance. And now currently they are ongoing on body weight below 10 kilos, even if the number of children were very limited. So this is possible with the concours of registries. Next slide. Very shortly, so these registries were set up since 2011 with a lot of details provided to characterize the disease, but also the outcomes of efficacy and safety of the drugs. Next slide. And finally, I will conclude that there is other pediatric developments, in this case for severe and progressive but rare kidney disease, in where anti-C3 oral small molecules, because we have a lot of PIPs in these very limited rare orphan disease, could be developed. But for that, we will need then the registries. They are set up with a number of thousands of patients, and therefore patients available could be captured. And even if they are increasingly rare, youngest subsets could be captured and provide information needed to avoid off-label use that in this case could have severe consequences. They are essential for innovation, this real-world evidence, including registries, more and more with the development upcoming, and the design should be improved, encompassing not only specified disease, but prospective as possible. And there's a lot of effort on that. And finally, I will conclude with the last slide very shortly on the things that there is ongoing an EMA concept paper on real-world evidence, including registry. We are on draft step, but the concept is because there are advances in technologies and the situation in where observational studies can be better placed, the objective are to value this data to define the key concepts and to provide legal provision of role and circumstances to use that as supporting tools for efficacy, for marketing authorization, and not only for the monitoring of safety, because randomized controlled trials are a needed tool, but these are complementary to fulfill all the needs. Thank you very much.
So thank you very much, Sylvie, for this very interesting presentation. So as previously specified, we will take, I'm sure, many questions at the end. Now we are going to welcome Professor Gilles Vassal, if he's with us. Professor
Hello,
Vassal.
can you hear me?
Hello, hello, yeah, we hear you very well. Thank you very much for being here. So, Professor Vassal, we are very honored by your presence. As MD, PhD, you have dedicated your life, at least years, to the development of new cancer drugs for children and adolescents. Gilles Vassal is professor of oncology at the University Paris-Saclay, head of the Pediatrics Oncology Research Program at Gustave Roussy Institute, chair of ITCC, chair of Accelerate Initiative, member of various councils. So, as of today, with more than 250 publications, Professor Vassal is definitely a leader of innovation, new approaches, new way of thinking for a new world, the real world evidence. So, if I may, we listen to you now. Thank you.
Thank you very much for this very nice introduction. And I would like to thank you for giving me the opportunity really to discuss with you real world evidence in pediatric oncology. If I may have the first slide. Yes.
That's okay. Yeah.
Just to set up the landscape at the beginning, cancer is a rare disease in children. There are more than 60 different pediatric malignancies. Each of them is a rare or ultra-rare disease, and as a whole, all these malignancies are rare according to the European definition. But it means that each year in Europe, 35,000 children and young people are diagnosed with cancer. The second information is thanks to all the research that's been done by pediatric oncologists in Europe and across the world, the current treatment can provide 80% of patients disease-free at 5 years, thanks to all the research done mainly by using the drug available in the pharmacies of the hospitals. But there are two important messages. First, there are inequalities in Europe because there are 20% differences across Europe in the overall survival of these patients. And the second information is that 2/3 of these survivors do have sequelae, long-term toxicity of the treatment they receive or their disease. And finally, there are still 6,000 deaths yearly by cancer in children and young people in Europe, making still this disease the leading cause of death by disease over 1 year of age. And our three objectives is cure more children, cure them better, and tackle inequalities in Europe by introducing all of these new innovative therapies. And for the purpose of this talk, clearly the need is to accelerate the development of safe and effective innovative therapies and their timely introduction in standard of care. Next slide, please. So what is the role of real-world evidence in pediatric oncology drug development? First, to provide the external controls to the single-arm trials that are and will be the basis of pivotal data for registration in rare or ultra-rare cancers, childhood cancer, and other rare disease. Second, to provide real-life data for the comparative evaluation by the health technology assessment bodies. And we believe that clearly an early interaction between the EMA and the HTAs at the time of establishing the pediatric investigation plan would best define what are the data needed for the evaluation by the EMA, but also the evaluation by the HTA. Third objective, to set up an efficient implementation of the long-term follow-up measures in pediatric investigation plans. And finally, to collect data on compassionate use and off-label use of new medicine in the pediatric population to assure first that it is done in a way that is secure for the patient, but also to feed new drug evaluation. So this is why there is a real need to set up data that can be used and sufficiently robust for the evaluation by the agencies. And our goal is to increase the quality and make them in a way that it can be used for regulatory purposes. Next slide, please. Next slide. Yes. Oh, the previous one, maybe. Thank you. Yes. So in pediatric oncology, we collect data. We work together and we collect data to learn about the disease and the treatment. So there are many disease and treatment registries in the field. I took two examples. The first one is the SIOP DIPG network. DIPG stands for diffuse intrinsic pontine glioma, which is a brain tumor in the pons of the patients, a disease with a median survival of 9 months and 95% of patients dying within 1 year. So in 2017, the SIOP network decided to build a registry of these patients, collecting across Europe cases of all newly diagnosed DIPG patients with clinical information, imaging information, and when available, molecular information. And since 2017, this registry collected data from more than 900 patients. The second example I wanted to share with you is the EBMT patient registry. EBMT stands for European Bone Marrow Transplantation, which is an organization which builds these registries of patients receiving either an allogeneic or an autologous hematopoietic stem cell transplantation. It was set up in 2014. And at the moment, as you can see on this slide, this is more than 20,000 people in this registry. Treatment registry, clearly data from the real world, not all of them being part of clinical trials. So if I may have the next slide, it's not only at the European level, but we are also able to collect data at the global level. I took one example. In 2004, 5 international cooperative groups decided to work together and to share data on neuroblastoma. Neuroblastoma is a typical pediatric disease occurring in young children, representing 7% of pediatric cancer, with an overall survival about 50%. They decided to join their data, and they built the INRG, International Neuroblastoma Risk Group, which is in 2022 having collected clinical and molecular information from more than 20,000 children with neuroblastoma, which is an asset of extreme value regarding this disease. May I have the next slide? So, talking about pediatric oncology drug development, this is an important message because we want to accelerate pediatric oncology drug development and to be able to really implement in a timely fashion the development approved by the authorities in terms of pediatric investigation plan or PPSR in the US. We built in 2003 ITCC. ITCC, what it is? It's a European network with 63 expert clinical centers in 16 countries and Israel, able to run phase 1, phase 1, 2, and phase 2 trial of new oncology drug. in children and adolescents. Yearly, it does represent 1,500 relapse patients, about 20 to 25 ongoing early first phase trial, with about 60% of them industry-sponsored and part of pediatric investigation plan, which is roughly 400 to 500 patients in trials. And in addition, through the program that have been developed, genomic profiling program, which is taking the tumor of the patient at the relapse and doing complete sequencing in several programs, as seen on the slide, MAPIAX, Inform, ITER, SMPED, and DANIX program. We are aggregating this data in a database or in a way that it will be accessible with molecular information and clinical information for research and for partnering with pharmaceutical companies. And at the moment, it means that more than not 300, but 3,000 exomes at relapse have been collected. So why I'm sharing this with you? It is because we are introducing real-world data in the ITCC program. And I would like to illustrate that by the situation actually in France about access to innovation for children and adolescents with cancer. On the next slide. So the next slide is a bit complex, but I will walk you through. In France, we do have a France Genomic 2025 program, which is a national program proposing all genome, all exome sequencing and RNA sequencing for rare disease and for cancer, including childhood cancer. So the process at the moment for any child in France with a relapse or refractory malignancies is first prescription of a molecular profiling in this program, validated by a regional tumor board. The result of the profiling is discussed at the national level in a national molecular tumor board to identify what are the relevant alterations in the tumor of this patient that would drive the proposal of a therapeutic options. And then from that, there is a recommendation on what could be access to innovation based on understanding the biology of the tumor of this patient. And as you can see on the screen, there are three options. The first one is the panel of phase 1 and phase 2 trials in ITCC, that the network I showed you before. And in France, they are implemented in the CLIP, which is the phase 1 pediatric center in oncology, which has been labeled by French National Cancer Institute, with clearly a portfolio of 20 to 25 trials per year available for those patients with a molecular profile. We do have the ACCE-ISMAT program, which is one of our platform trials. The goal was to have an academic trial that would be able to really set up in a timely fashion new proposal of phase 1 and phase 1/2 for those patients being introduced in the European molecular profiling program. And this ACCE-ISMAT that was being supported by the National Cancer Institute in France and several non-profit organizations is a European trial. We have already since 2016 evaluated 12 new compounds, including 8 first-in-child compounds in phase 1 and phase 1/2. But despite these options, despite this portfolio, there are still a need to propose for these patients with a molecular profiling a treatment which is either off-label or used through a temporary use authorization, which is the mechanism, the tool in France for experimental projects. So clearly this is a real life. Daily, pediatric oncologists prescribe off-label drugs to patients or get access to experimental products in ATU. And we said we cannot leave it at this. We need to collect information about this use in order really to secure the use for the patient, but also to feed when there is any evidence of activity to feed the development of this medicine in children. So on the next slide, we built SASHA. SASHA is an observational, non-interventional study under Roy-Jardet, type 3, for secured access to innovative medicine for children with cancer. It's a prospective collection of toxicity and efficacy data when patients have been already treated, either with the off-label use medicine or with a medicine under compassionate use. It is open to any patient under the age of 25 years old with a relapse or refractory pediatric malignancy. And this fits at the moment in terms of compassionate use, the further nominative ATU, which are now compassionate access, and also the previously called ATU, which is now early access. And for the off-label, we consider all new medicine that have been first approved in adults be after 2007, not 2017, but 2007. Sorry for the mistake. Clearly, the 2007 is the date the pediatric regulation was launched and entered into force in Europe. So the goal is to collect data from this use for patients who are not participating to clinical trial because there is no option for them in those clinical trials. On the next slide. So the principle is very important. Any patient in France with a relapse disease, the case is discussed in a multidisciplinary interregional tumor board to really to define what is the best option. Because our goal is not to deviate participation of children to the open clinical trial. The goal is really to continue to discuss first for any child what is the option possible for a phase 1, phase 1/2, or phase 2 trial. And if not, whether there would be a drug, either off-label or compassionate, that would meet the needs as defined by the molecular profiling of the patient. So as you can see, we opened the SASHA trial in March 2020. A month in 2020 where things were happening in terms of COVID and so on. And now it's open in all 32 centers in France, which is important. We are comprehensive in all centers. We are in a situation to prescribe this drug off-label or through ATU. On the next slide. So far, over the last 2 years, we have recruited 283 patients in 22 months. And as you can see, we just said it might be 150 patients per year. It was just like an estimation or a guess. And clearly, it's amazing that clearly we have a curve of inclusion absolutely fitting to this 150 patients per year. Whoops, I don't see any more my slide. But that the good news, I prepared this, and I know if you can see still my slide, which I do not, I can continue on the slide with a curve of inclusion into SASHA, where clearly at the moment on the right-hand side, you see that it has been 52 drugs prescribed to this patient, either off-label or in a temporary use authorization, about 2/3 of them in ATU. We have a good and a systematic pharmacovigilance declaration system because we collect information from the use of this drug in patients. And we have been declaring 21 serious adverse events through the classical, usual pharmacovigilance system. And in addition, we opened the larotrectinib cohort. Why? Because clearly there was a need to collect all information for all children which have been treated for this drug, which is approved now for the treatment of fibrosarcoma infantile and soft tissue sarcoma in children, a need to collect all information in all the previous ITUs, and a request from the French HTA, la HAS, to collect prospectively, comprehensively, the information of larotrectinib being prescribed and the marketing authorization. And we opened this in the SASHA to collect on the territoire of France comprehensively through the 32 centers who are committed really the data for this cohort. So in conclusion, what are we expecting on the next slide through that? We expect to monitor the off-label use of anti-cancer medicine in children and adolescents. We expect to have a comprehensive collection of safety and efficacy data for anti-cancer medicine, newly ones, either prescribed as compassionate or early accesses program, as mentioned previously in France. We anticipate to have adequate pharmacovigilance declaration, and we know that events in oncology are under-declared in the pharmacovigilance system. And with this system, we plan and we demonstrate that we have a correct declaration for this SAE through the PV program. And the output is what? Recommendation for the sake of patient to stop prescribing those medicines if there is an unacceptable toxicity or a lack of efficacy, especially when these medicines are expensive. But on the other hand, when we see some efficacy signals, to discuss with the company to build a program for development, because it would be from first evidence of efficacy that would support the development in children. And finally, the outcome, which is already there, is a really committed community, really working together, really to generate this data, which I think is very important in the way of how to assure the collection of data in a rather comprehensive fashion. Next slide. Based on this experience, we are transforming this in a SASHA international program through ITCC. It will be open in Italy, Spain, the UK, Netherlands, Ireland, Australia, New Zealand, Belgium, Austria, and Denmark, and maybe others, really building on this pilot experience in France to be able to collect across ITCC data for this use of new treatment outside of clinical trial. But keep in mind that we say the first thing is clinical trial participation, and we will monitor that clearly getting data from the out of trial situation will not impact negatively the participation to clinical trial. Finally, the other example on the next slide, please, is the long-term follow-up. First of all, I would like to thank, because I described quite in detail this SASHA program, all the families, the people, and also ANSM, because clearly we are working with Isabelle Jodland and Jora Brunel, and we are establishing an excellent partnership. And we receive regularly what are the prescription of ATU by ANSM in order to be able to collect all information for this patient, to be comprehensive in the system. And this is funded by non-profit organization like Fondation Lem. On the next slide, please. I'm almost finished. The last topic I would like to touch is long-term follow-up. Within pediatric investigation plan, there is extremely often this concern on potential long-term safety and efficacy issues in relation to pediatric use at the end of the pediatric, the PEP, as available publicly on the website. And the key question is how to collect this information. Because clearly pharmaceutical company cannot or very difficultly set up for each of the assets a long-term follow-up program, especially when it is more than 5 years. So on the next slide, within the Accelerate platform, which is a multi-stakeholder international platform with everyone around the table, we're the working group to propose a registry, a specific initiative to collect long-term follow-up data of children receiving new medicine approved for the treatment of pediatric malignancy by reusing the data which has already been collected by academia on the long-term follow-up and making this available in a way that it can serve the regulatory request on long-term follow-up for the industry and their new medicine. So next slide, sorry, next slide. Just to touch base something that we believe that there is an issue at the moment, because clearly the harmonization of the GDPR makes things difficult because it is the implementation of the GDPR makes things difficult because it is difficult in terms of different implementation and interpretation across member states. And clearly we believe there is a need to improve or facilitate the data sharing and biological sample sharing by making some modification in the implementation of the GDPR. The final one, sorry for that, next slide. So in conclusion, we have many academic registry in pediatric oncology. Not all are yet set up in a way that they can really generate robust data and that would be regulatory compliant. Second, there is a real need to increase the strength of external controls from real-world data through this initiative. A need to set up early dialogue, as I mentioned, to define early what is needed, including the real-world data that may help the HTA to evaluate and comparatively the new agent with what is the current treatment in the given disease. There is a need to facilitate sharing, and clearly we say the European pediatric oncology community is very keen and ready to work with EMA, HTAs and industry to make it better and accelerate innovation for children with cancer. On the next slide, I think this is my conclusion. And I thank you very much for your thank you very much. I cannot say more. Sorry.
And thank you very much. Thank you very much. You, Gilles Vassal, for your presentation. Thank you both for your clear presentation, focus on pediatrics. And regarding the limited data in pediatrics, it's quite easy to understand the interest of real-world data and real-world evidence to complete clinical trial. But it is easy to say. Sylvie, first question for you. How do you work together with pharmaceutical companies in order to obtain robust clinical pediatric studies based on real-world data and registries?
Gilles Vassal on that, because what we have at national level is what we call Guichet Innovation and Orientation, which is an office for innovation and orientation to help the academics and patients, organizations to interact earlier with the concours of the companies before to step and to build on a clinical study that perhaps could be not enough to ensure the market and authorization, and in addition, the market access, which is key, essential for each of the patients. And in addition, I will encourage the academics with the concours of the pharmaceutical companies to submit earlier a pediatric investigation plan, at least at the end of phase 1 in adults, with preclinical data and Moderna simulation PK/PD to ensure essential information in pediatrics earlier on, before that the studies are already initiated. That is a major issue to ensure that real-world data and registries could complement the needed randomized clinical trials when possible. Thank you very much.
Can I make a short
So another question for you, Sylvie, and thanks again. What are the difficulties encountered in the integration of different registries databases at national and international levels, please, according to you?
C'est pour Gilles ou pour moi?
You may answer with Professor Vassal if you wish. Yes, this can be a common answer if needed.
Well, I was just wanting to comment on the previous question, just to share with you that we strongly consider that there is a need to run clinical trial in children. Phase 1, phase 1/2, randomized trial, and we run randomized trial in children with cancer. So clearly this is not an option to not do it, but when we cannot, to generate the real data. And the message from the SASHA experience is also, we don't want to have this deviating what is needed for the full and clear and good development of pediatric medicine. And I feel that some people, maybe in industry, would say that maybe in the field of pediatrics, if we have good large database of real world data about drugs, we can avoid running clinical trial. I think this is wrong. And our message is clear. We want to collect information, but we need full good development that will turn into marketing authorization, and when we cannot do randomized trial, the use of good external control and evaluation for HTA is clearly something that can be done. Sorry for that.
Thank you very much. That's very clear. And we have another question for you, Professor Vassal. So huge progresses have been made this past year in pediatric cancer treatment, so that more and more patients are now cured. But the next goal is probably to cure better with less sequelae. You have mentioned the long-term follow-up and so on. So in your opinion, how real-world evidence could contribute to this? Could you please elaborate a little bit about this, your own approach, please?
Absolutely, absolutely. The first measure is that at the moment the survival curves are plateauing. So we see new medicine, but it's not yet that we cure more children. This is clearly in the next 10 years that we need to increase the number of patients cured with a new medicine. And the long-term follow-up is extremely important. In pediatric oncology, we follow our patients, children, and then becoming adults, childhood cancer survivors, in the data, following them, anticipating the sequelae they may have, and making the transition with adult medicine to be sure that they are treated appropriately. And there is a great program called PanCare in Europe, getting all this initiative for childhood cancer survivors. But at the moment, this information is not anticipated to be used for the long-term follow-up that measures that are needed from the pharma. And this is important. We have now CAR T cells, we have now blinatumomab, we have now dinutuximab, brand new medicine with new mechanism of action. We don't know what it will be in the cure patient in 10, 15 years from now. So clearly the experience that we had so far, very strong with all the previous treatments that were being followed in this patient, anticipating in the cure patient what would be the toxicity. We want to set up a system that clearly can anticipate the toxicity of the brand new treatment by getting this data from the real world and make it available on one side for the industry to comply with their regulatory requirements, and on our side to make the research and the program to avoid or decrease this toxicity. So it's absolutely an important topic, real-world data in long-term follow-up in childhood cancer survivors.
Okay, thank you very much. Thanks again.
Yes. Thanks a lot, both, for your participation. It's time to conclude a very short conclusion. Because of time. We have seen in this session that real-world evidence is used for a long time for safety, but it is still the main objective. And beyond pharmacovigilance and safety, there is an increased use for clinical development, effectiveness, comparative effectiveness, drug utilization and specific population, rare disease, pediatrics, oncology. And it is clear that the use of real-world data and real-world evidence is accelerating, and that regulatory agencies face multiple challenges. And this is maybe a word to introduce our round table. And so we need, I think we need a few minutes, few seconds to fix the round table. So please wait.
Ladies and gentlemen, welcome back to our conference. This two-day conference has been a great opportunity to share across the European member states on the collection and the use of real-world data. It is noteworthy that today, the use of real-world data is largely going beyond the historical field of pharmacovigilance and post-authorization safety of drugs. Now, the pharmacoepidemiology is largely producing studies that are reinforcing the knowledge in the safety of drugs, but it also today could address the efficacy of the drugs by the means of the real-world evidence. We finally saw this morning the potential for the real-world data to be included in the pre-authorization application as a complement to clinical trials. As illustrated by the initiatives for creating common data models, the cornerstone is the ability to integrate data from several health databases within the European health space, with several challenges of quality check. Then, as shown by the Darwin process for conducting studies, the general scheme to go forward in a scientific driven way is the parallel connection of top-down and bottom-up processes. This means the need of coordinating entity, identifying the question, the data partners who are running the code, the coordinating entity that is integrating within a decision-making process. Having this map in mind, two questions could be raised. Are the regulatory agencies today being sufficiently competent in this new area of expertise? What kind of skills, what type of organization would allow adequate involvement of the regulators? The second is about the patients. Patients are the main source of any health data and finally of the decision-making process. How are they involved in the processes? What could be the level of trust in such a somehow cloudy system? I am proposing you to stay a little bit on these two questions by the means of our roundtable inviting representative of data partners, coordinating entities, and the patient representative Virginie Yver. Virginie Yver is the Therapeutic Development Director of EURORDIS, that federates European Association on Rare Disease. She has 20 years of work experience in research and healthcare, including 30 years in the rare disease field. She has been deeply involved as a patient representative in the EMA, observer on the COMP, alternate member on the PRAC, and working together with the other patient representatives. At global level, she is involved in the International Rare Disease Research Consortium, IRDC, since its inception in 2011. And I am very glad to welcome Virginie on this roundtable. The roundtable will be moderated by Patrick Maison, who is responsible of the scientific delegation at our French National Agency. Please, Patrick, I give you the floor for this roundtable.
Thank you, Christelle, and thank you all of you for being with us virtually or physically. The idea of this roundtable is we would like to learn from your experiences and to share your advices, your opinion on this is two questions. And if I summarize how to involve assessors in the regulatory agencies and how to involve patients. I suggest to, if you don't mind, to start by the question of skill. And in order to cope with what can we call the data transformation, regulatory agencies face several changes. They need the right technologies, regulatory setting, guidelines, procedures, and so on, but they also need new or greater expertise in the field of big data. Jasper, maybe if you don't mind, Jasper, you are the co-chair of the Big Data Steering Group. And to your opinion, what are the challenges that we face in terms of capabilities and competencies and how to deal with them? Please, Jasper.
Sure. Now, I think we did part of that analysis and survey last year when we actually did survey all of the NCAs of the knowledge they had in the realm of big data, and it became clear to us that there was a knowledge gap. because analyzing data and using data is not the same as actually being well versed in understanding the information and the knowledge it generates. If you want to take that step further below, then obviously you need other skills in order to succeed in that. And that's out of that, we defined that we definitely needed to build curricula for pharmacoepidemiology, biostatistics, and for data science. It's a fast evolving field, for one thing. But also the opportunities that come along with the data we can get access to, we need to benefit from that. And I think everyone can actually recognize that there's an important piece in doing so. It would almost be immoral not to do so going forward. So I think we just need to seize that opportunity and then just go ahead and get the right competencies in place. In addition to that, some of the competencies we don't have. In the discussions we've had between the NCAs in Europe, we've come to see different models where we can actually collaborate closely with academia. And we have done that in the past, and we need to continue to do so. So I think collaboration is also part of resolving the knowledge gap, you can argue. So very much looking forward to that, whether that happens within Darwin EU, whether that happens within other initiatives under both HMA and EMA, it just needs to be seen. Looking very much forward to that.
Thank you, Jasper. Now, maybe a question for Mahmoud. Yesterday in your presentation, you present your team with different profile in it. And how did you manage to set up your team and to manage the question of human resources? And what were the main difficulties in setting your team?
Thank you, Patrick. I think the real-world study shown in this conference yesterday and today, the real-world studies have become increasingly very important in providing evidence in the assessment of benefit risk in health products. The value of the real-world data has been recognized by regulatory bodies such as French authority and ANSM, but also other European countries, by FDA and by European Medicine Agency. To answer your question, Patrick, I think the regulatory agency must have a clear strategy in the place of real-world evidence. This strategy, once this strategy is developed, discussed, and adopted, arise the question of its implementation and the necessary means to implement this strategy. I think there is a real need to have high-level scientific profile inside the regulatory agency, such as pharmacoepidemiologist, part-time clinician, biostatistician, data manager, and data scientist, and pharmacologist, and to develop focus and long-term partnership with independent academic team. At EPFAR, we have a strong partnership policy to develop pharmacoepidemiology in France by funding research subjects, by finding PhD programs and hospitality for PhD students and postdoctoral students, and by finding two centers of pharmacoepidemiology, first one in Bordeaux, the second in Lyon. I think also it is need to develop links with expert networks, clinical, pharmacological expertise, and patient partners to deal with rare resource, dealing with competition with private bodies. The regulatory agency must be attractive and must dedicate funds for real-world evidence. I think we see there is need to European cooperation by experience sharing, by development of common methodological to facilitate and facilitate interagency exchange. All of that, just a word for there is still a need also for just word for data. There is still a need to strengthen the type of available data and to improve the quality of data. The data in the real world must be valid, reliable, and reproducible. I think there is room for improvement for existing real world data. If we take the example of the French system, SNDS, French National System of Data, we could enrich, data could be enriched by some important variables such as body weight, smoking, and alcohol consumption, etc., etc. Last word about the access to data. I think aussi there is need to improve accessibility and fast access. Is need to secure organization and data sharing, of course, to take care of legal and regularity issue to protect personal data.
Thank you, Mohamed. Another question, maybe a little bit more practical. You are both agree with the interest of the collaboration, high-level expertise, but do we need also to train current assessors to facilitate the dialogues with experts, for instance?
What we are doing, we have several PhD students and postdoctoral students, and we have some committees of experts about specific subjects.
Okay. Now, Roman, maybe the same question, because the French Health Data Hub is a quite new structure, and you also have to recruit. This is last year's with, I suppose, different skills. What do you have? Do you have the same difficulties, and how can we be attractive?
So there are two ways to answer this question. The first point is that the Health Data Hub was created quite recently, and it's of course a public structure, but in the French law it's a groupement d'intérêt public, so it's a public structure but which has some freedom in its way of recruiting people, and also some freedom in the salaries we can propose to people, as opposed to other public structures that are really restricted in the way they can make deals with the potential candidates. So this gives us a little bit of freedom to recruit, to be a little competitive in this market. Of course, we are not as competitive as the big companies, but what we try to put forward is that there is a meaning in working with us, there is a meaning in working with the state, and in contributing to build this policy of health data on the long term. It's a new structure with lots of very motivated and innovating people already working with us. So we are quite attractive, especially for young, talented students who come out from those really good engineering schools we are lucky to have in France. So we have some potential to recruit. Of course, the profiles we are looking for are not that abundant, and there is a big competition with the large companies that you all know, the big search engines and all the big data companies. But still we managed to be competitive by combining this focus on the meaning of the work and a little bit of freedom in adapting the salaries of our job offers. And to drift on the question of training, we also have quite a few initiatives related to training potential data users and data analysts, and we are now building, contributing to build a postgraduate national degree, which will concatenate a few initiatives that already exist in France, put them together and focus it on a more accessible to a more large public and with more accessible content, because there are lots of training programs available now in France related to data, but most of them are focused on people who already are very sensibilized to using data. So we are working with three universities, including the one where I am teaching myself and two others in France, Bordeaux and Marseille, to build a national training program that could be interesting for people working in regulation agencies, for doctors who are not really familiar with working with data. And we really believe that there is a space for creating such a training program. The Health Data Hub itself is not a university, is not a teaching body, but we can work with universities and bring our practical expertise on dealing with data to some academics who have the real knowledge of data science, and putting all this together offers something that would contribute to increase the training of people who don't have the strong basis in statistics or preliminary, who have never done preliminary work with data. So those two aspects, the facilitation of hiring new people and also getting involved in training, I think it will create a positive, some positive movement and help to promote our structure and hire the right people.
Okay, thank you, Roman. So it's you mean it's maybe a solution, a good proposition for the assessors of the agency?
Yeah, I think this training program will be very accessible to people, of course, who are interested in data, but who don't have a strong statistical basis and who haven't done themselves extensive work on data. So, for instance, assessors of regulatory agencies or consultants, doctors who have interest on data, but who don't really know how to deal with this new complex world.
And now another question. We talk a lot about collaboration, partnership, and what about the HDH policy concerning partnership? Because it's not a private structure, the SDATEP, so it's quite easy for an agency to collaborate with this kind of structure.
So the HDH is a public structure, and we have lots of different types of partners, and we try to build exclusive partnership with all the different sources of potential sources of data, and for two reasons. First is to promote the federation of data providers in France by helping to build, for instance, local data warehouses in hospitals. I will give you a few details about this project, and also to increase our own catalog of data. Concerning, if we take the examples of hospitals, more than half of the content of our catalog comes from hospitals, either private big university hospitals or other health structures. So we are trying to work also with hospitals and also with the Ministry of Health to build a national policy for funding and federating the building of all the data warehouses within the country, because we are now at a specific moment where there are lots of multiple initiatives, lots of strategic choices that are being made in all the major hospitals in France, and we need to have a federating body which is different from a hospital, like a single hospital, which would be the Health Data Hub, that will help to make the right strategic choices in terms of sharing data, in terms of governance, in terms of economical model. So that's what we are doing now, and our aim is to create multiple partnerships with the largest number of hospitals in France, both to share data and also to federate the strategic choices. And we believe that this should happen in the next few years. Otherwise, it's going to be too late for building those partnerships. And the work we have done so far has been quite fruitful because we have managed to convince the major authorities, the Ministry of Health, that building partnerships within hospitals and within data providers and building data warehouses is really a national priority and should be supported by the state.
Thanks a lot, Roman. And now I would like to focus on our second thematic. One of the priority recommendations of the Joint Task Force on Big Data was to dialogue actively with stakeholders and above all patients. And furthermore, we saw during the COVID-19 pandemic that patients and public were also sensitive to scientific evidence. And during the previous presentation, we saw that trust and public trust is an important goal for all speakers. And so we should work with patients and citizens, but the question is how to involve patients in this development of big data. So Virginie Hiver, you are patient representative. You are the voice of rare disease patients in Europe. And we saw that there is a strong interest of real-world data and real-world evidence in rare disease. Could you give us the patient point of view, at least your point of view concerning data and evidence? And because trust matters, how should we involve patients, or how should patients be involved?
Thank you. That is a vast question. So first of all, I wanted to thank you for the invitation. And maybe, well, as a preamble, what I wanted to say is to give you also a few figures that we have collected amongst our members and amongst rare disease patients in EU and beyond. So, I mean, you've said that real-world evidence are very crucial for rare disease patients. Data in general is gold for patients. It's even more gold for rare disease patients. Rarity comes with scarcity of data, so that is really an element that we have to keep in mind. And when I was saying that we have some figures that I wanted to share with you is we have a program that is called the Rare Barometer program, and we are running surveys with this program on the patient living with rare disease in Europe and in the world. So we have had 2 years ago, one of our surveys that was really targeting the feeling, the perspective, the preferences of patients with regard to sharing their health data. In this survey called Share and Protect Our Health Data, we had 2,000 respondents, which for rare disease field is quite large amount of respondents. And what comes out really strongly from this survey is that rare disease patients are really willing to share their data. So that's the first point. Whether, I mean, regardless of the severity of their disease, regardless of their socio-demographic profile, they are willing to share data. And almost 100%, like 97% of the respondents say that they will be ready to share the data to better understand the mechanism of their disease, but to also to develop new treatment to improve the diagnosis of their diseases. And this is really higher compared to what we have in terms of figures in the most general population, where in general we have figures around 40% to 80% of willingness of sharing data. But this comes, as you have said, with also some counterparts, meaning that rare disease patients are really willing to share data, but they also want to keep control. And meaning control is knowing what will be done with their data, what will be the use, which type of stakeholders will be in use, will be reusing their data. And also, I have maybe a few examples of why this willingness of control, what are the risks that are seen by the rare disease patient with the data sharing. And for example, half of them see as a risk that the information that they are providing can be shared with a third party without their consent. Almost also half of them fear that the information will be used in the different context that the one for which they accept to do it. Also, something that is very specific with this context of rarity is that you have the risk of being discriminated, because if you are in a rarity space, then you might be identified based on your data. So all this comes with, of course, some measures that have to be put in place to prevent those risks, and also collectively, I mean, to protect the patient, but also to ensure the data sharing. So maybe just a few points, and I'm also happy to discuss with you more, but what we can do to really ensure both the trust of the rare disease patient, the control that they can have on their data, but also to ensure that we can make the best use possible of those data, is to involve them. That might sound naive or general, but that's really key. So to involve them, for example, there are patient representatives that are on the steering committee of Darwin, this initiative from the EMA that was mentioned previously. So that is a very, very crucial point. In the rare disease space, when you talk about real-world evidence, you immediately have in mind the potential of data that are generated in the European Reference Network. So here again, we have patients that are involved in each of the 24 ERN, in the governance, and also in several activities. But this, of course, comes with training. It was mentioned for the healthcare professional, for the regulators, but it's also true for the patients. You need to provide the patient with the right tools to really grasp what is at stake, to really understand all the challenges, not necessarily all the technical aspects, but really to be able to contribute meaningfully. So maybe I can stop here for the moment. Thank you.
Thank you, Virginie. Also on this question, maybe for Mahmoud, how it is possible to involve patients in the real-world evidence process?
At EPIPHAR, just a reminder for EPIPHAR, which is a scientific group created by French National Agency for Safety of Medicines and Health Products, NSM, and French National Health Insurance. EPIPHAR carry out pharmacoepidemiological study. At EPIPHAR, we don't have a dedicated body, a specific committee involving or including a patient. But patient association don't hesitate to contact us after, for example, after the publication of our study report, and of course we discuss with them. In fact, at least currently, patients are not expert for real-world data. We use their health data, and we must have a strong credibility towards them. This leads to 2 points. First one, the necessity for national competence authority to discuss with partner patients at different level of dedicated bodies. I talk about pharmacoepidemiology. This implies there is mutual understanding of each other, and it's important to develop real-world evidence skill for patients. I think, however, then that national competent authority don't have formation capability to nor official mandate for performing formation, but need to encourage patient to continue generated data, patient-generated data, to engage strong formation for a better understanding of real-world evidence about methods, about strengths and limitation of real-world study. Second point is that national authorities have strong responsibility toward patients and must demonstrate that their credibility toward patients. Actually, they must work in transparency of their work, their process, their scientific robustness. For this last point, it is necessary for national competent authority, such as ANSM, to publish their work in peer-reviewed journals and rely on independent scientific review. I think by joining credibility, scientific robustness, and strong formation of partner patients, we will able to work together for the benefit of patients and population.
Thank you, Mahmoud. I would like to go back with Roman. To my knowledge, one of the 4 axes of the HDH strategy is based on data transparency, and we have to talk about transparency if we want to explore this question of public trust. Could you give us more detail about this strategy?
Yes, of course. So there are two points within the organization of the Health Data Hub that are relevant regarding the relationship with patients. First of all, the president of France Asso Santé, which is a cluster of a large number of patient associations, is at the very top management of the Health Data Hub. So the structure is governed by people representing patients at the very top of the governance. Then the second point is that the Health Data Hub is built upon 3 offices. There is the scientific office that deals with data. There's the medical office that I lead that deals with relationship with health professionals. And then there is the patient and citizen office that deals with relationship with the general public and with patients. So really 1/3 of the main structures of the Health Data Hub is dedicated to the relationship with patients. And this office is very active and makes communication campaigns, builds designs specific documents, is in touch with lots of patient associations, so does a great work in familiarizing patients on the work that's done with their data and trying to screen what are their concerns. And more precisely, in order to screen the concerns of the patients and to understand what they think about what the use of their data should be and what is their own perception of those issues. Part of the European projects currently going on. Earlier this morning we mentioned 2 main focuses of the Health Data Hub related to the European projects. One of them was the design of the European Health Data Space, and the other one was a project called TEDAS, which is a major pan-European survey about lots of topics. And one of the work packages of TEDAS is focused on the relationship of patients with data. So the Health Data Hub is leading this work package, and there are 3 countries involved. There is France, Belgium, and the UK. And in each of these countries, we're asking the same patients to a great variety of patients, people from the general population, students. So we have a few focuses, and the questions we ask them are about what are they afraid of, what do they expect from data, what do they would like to see change in their relationship with data. So there's a list of questions, and we will compile all those, and then hopefully we'll have a clear idea of how we should direct our future policy related to the concerns of the patient. So to sum up, both at how the Health Data Hub has been built around the concern of the opinion of patients on the use of their data, because we're a national body and this data belongs to the patients. And then in the future, we are assessing the relationship of patients with data and of the general population with data in order to make the best choices when those choices are related to the data of the patients.
Thank you, Roman. Gianluc, I come to you for sharing your experience at a national level. You presented yesterday, yes, I think it's yesterday, the Valore project in collaboration with the Italian Drug Agency. This is a national network integrating data from regional claim databases, clinical registry, and so on. From this national experience, and by the way, very interesting project, how did you manage to get the right skill, and did you involve a patient in this project, and how?
Thanks for the opportunity to national. Can you hear me?
Yes.
Okay. Well, first of all, let me say that we talk more and more about real-world data and real-world evidence. I think when we are in the field of medicines, we should remember that we should discuss about pharmacoepidemiology. That reminds us that we are talking about a discipline, scientific discipline requiring rigorous methodological approach. So we should shift the focus from talking about access to the data, real data, towards access to education on how to handle the data. And because I think it's much more risky to have unexperienced researchers accessing large volume of data than having restricted access to data by very experienced pharmacoepidemiology. So this is a first general consideration. Another consideration is that we should set up a very strong collaboration between regulatory agencies and academia. This has been happening in several European countries, the Netherlands, but also in France. Several PhD programs are funded by national authorities. I think this is very good example on how to liaise. We are running at the moment a master program together with the Italian Drug Agency and the Italian Association of Pharmaceutical Industry, because there is a need to customize education to the needs of regulatory agencies. And also, I mean, we should invest energy in educating undergraduate students, because I think it's not only a technical issue when we talk about pharmacoepidemiology, it's also a cultural issue. We need to make future healthcare professionals aware of the great opportunities that are offered more and more by real-world data. And if we think about the potential of all the patient-derived data based on all these digital tools that will be invading the clinical practice more and more. Patients should be involved both in the education, so the cultural process should involve patients that should be aware, again, about the potential of real-world evidence and the need to generate real-world evidence to integrate pre-marketing evidence from randomized clinical trials. I think the pandemics and particularly vaccine development showed us how important it is to integrate real-world evidence. Also important is to, we did it in the context of Valore project, to liaise with patients to prioritize what are the research questions to be addressed. And here I would like to mention a very interesting study about cystic fibrosis, in which a number of outcomes related to drugs that have been marketed for cystic fibrosis treatment have been compiled and been listed, and it was asked to physicians and to patients separately which were the most important outcomes to be explored based on their opinions. And there was a disalignment between the most important outcomes for physicians as compared to what was really important for patients. So it's very important to engage patients also in setting up priorities, and we have done this. So we had a publication committee for the Valore project where we engaged also patient organization, and they really provide actively feedback on what should be, based on their opinion, the priorities in terms of data analysis to be done with this large volume of data. I think this is a very important exercise, and we researchers, we really need to be guided by input from regulatory agencies, but also from patients. So I wish in the Darwin, I heard in the Darwin Coordination Center also patients are involved, and I think this process may facilitate in general involvement of patient organization in those large networks at both European and national level. So these are my main considerations.
Thank you, Gianluca. Maybe I go back to Jasper. Maybe do you want to add something, for instance, concerning patient involvement, or concerning your experience at the Danish agency?
I'd be happy to. I think it's super important to make use of their input to really guide us in the right direction. That's one approach. But I'm also recognizing the ability of citizens in general coming out of COVID-19 to have increased health literacy. I mean, we are in a unique, fantastic situation that we need to realize that people have actually started to learn what the value and the meaning with their healthcare data truly is. It's just amazing we have that opportunity. If you look at where we stand on a democratized system in the European Union, this is something we need to foster more. It should be part of a democratic society that you also appreciate your own healthcare data, what it can do for you, and also the altruistic use of that with others, right? And that comes so much important that we need to have people educated around it. We need to have them educated, and they need to absorb that on the trust relationships where they can use it with like the French Data Hub or the Danish Health Data Authority, where that's being put to good use. But reality in the future is that we'll probably start to see that it's not healthcare professionals creating healthcare data to treat the patients, it's patients themselves generating data where they can go and seek treatment. So they come more in control of their own health data. And we need to make sure that the benefit coming out of COVID-19 of health data literacy, we foster that even more. It needs to be part of general education, to have a curricula, to be trained in understanding that. I really would like to see that. And that completes a completely game changer for how we can use healthcare data in the future.
Thank you. So it's time to end this discussion. And any of you who would like to add something? Mahmoud, Roman, Virginie? No.
Yeah, maybe just to say that I really like what was said by the previous speakers, because the other point I wanted to mention is that indeed patients are not only providing data, they are also proactively contributing. So the example with the cystic fibrosis study is a very good one. That we have also others members in Eurodis, for example, in the rare disease from Dravet, from Duchenne, who are at the forefront of the expertise in terms of data setting platform. Like I have in mind the Duchenne data platform, Dravet platform, and they are really, collecting data also with the view of using those data in regulatory decision making. So this is coming up in addition to everything that is done, of course, at the level of clinician, academics, and researcher, but patients have a key role to play as well in there. So thanks all for your comments on that.
Thanks a lot, Virginie. So any of you, no regrets? So it's time to close the discussion. And Christelle, I give you the floor.
Okay, thank you very much, Patrick, for managing this very important roundtable. So now this is the time to conclude this conference on real-world evidence. I think that these were two fruitful days, and you were several hundreds to follow it, and many thanks for this. Many thanks for that. I hope that you could find answers to questions you had on real-world evidence topic, and that the discussions which have opened perspective in your area of work. It was stressed all along the conference that collaboration is the key point, really a key point for successful use of real-world data. Collaboration at each stage, collaboration in the construction of the reliable platforms and other common data models, but also collaboration in the analysis of the data involving a large panel of skills, and close collaboration with patients as a lighthouse for guiding the decision-making process and to enhance the trust. More broadly, we are really at a turning point because real-life data management will disrupt both our evaluation methodologies, but also our organizations. Strengthening of networking, acceleration of research, regulation methods. This will accelerate the development of innovation. It is therefore a real short-term challenge for our national agencies and European agencies and our organization within all in the European Union and in the international world. The increase in the management and the use of data will enable us to strengthen patient safety as a role, but also to respond in an increasingly personalized way to each individual, particularly thanks to artificial intelligence and the revolution of which is underway. The scale of the European Union for this new challenge is essential because it is the quantity of data and its cross-referencing that will enable us to refine our systems and be competitive in the world. That's for sure. This conference, organized under the French presidency of the European Union Council, was aiming to participate to the appropriation by stakeholders about the use of real-world evidence and in the regulation of the drug products. This is the beginning, and lots of work are to be done in the next months among the European Regulatory Medicines Network. I would propose to my Czech and Swedish heads of medicine agencies who will take the next presidencies in the next two semesters to pursue on this very important thematic in order to adequately face the challenges raised in this area. I would very warmly thank all the speakers for these 2 days for their high quality presentation. Many thanks to Virginie, to Jesper, to Roman, to Gianluca, to Mahmoud, and to Patrick for the very interesting points raised during the roundtable. I also thank the moderators, the chatters, the technical team for the management of this conference. As a reminder, our conference will be available online in an English and in a French format as well on our website. Thank you to all of you, regulators, patients, healthcare professionals, for attending to this conference. I wish you a very good end of day. Thank you so much, and bye-bye.